Good morning, everyone. We are continuing the inquiry under Section 59 of the Medical Schemes Act. Today, we are expecting the testimony of both Discovery and Discovery Health. We usually start with the oath, but it depends on who will be doing the presentation on behalf of Discovery. Perhaps you can introduce yourselves, gentlemen and ladies.
Good morning, Mr. Chairman. My name's Jonathan Broomberg. I'm the just former Chief Executive of Discovery Health. I will be making the presentation on behalf of Discovery Health. My colleague Charlotte Santella is with me on the left. She's the Acting Principal Officer of the Discovery Health Medical Scheme, and she will make a short presentation after my presentation. So it will be both of us representing Discovery Health and the Discovery Health Medical Scheme, if that's okay with you.
Thank you. Yes, that will indeed be acceptable. The experts who prepared your rebuttal of Dr. Kimi are internal experts. They are not external experts.
Yes, that's correct. They are members of our employees of ours, although we have had the analysis externally reviewed as well.
Yes.
But the people who did the work are our own people.
And they will not be testifying to it. You will be covering it in your presentation.
Correct.
Thank you. Well, let's do the following then. Dr. Broomberg, I take it, yes.
Yeah.
Will you take the oath or the affirmation?
Certainly.
Yes, all right. So will you say after me, I, and your full names?
I, Jonathan Broomberg,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth, and nothing but the truth.
and nothing but the truth.
If so, please raise your right hand and say, so help me God.
So help me God.
Thank you. And your colleague's name is?
Don't introduce yourself.
Good morning, Chair. I am Charlotte Mandisa Sangwela.
Mandisa Sangela.
Yes,
So, Miss Sangela,
Charlotte. Yes.
or Dr. Sangela?
No, not Doctor.
Okay. We have had a lot of doctors here. So.
I can imagine.
Will you then take the oath or the affirmation?
Okay.
Yes, so will you raise your, well, not yet. Will you say after me, I, and your full names?
I, Charlotte Mandisa Sangwela,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If so, raise your right hand and say, so help me God.
So help me God.
Thank you very much. Dr. Broomberg, we have no prescribed method of presenting the evidence. I take it there is a PowerPoint presentation, so you can pretty much run through it as you please.
Thank you, Mr. Chair. And just before I begin, can I thank you and the panel for the opportunity to present today. I think you are aware from our submissions, we've taken this inquiry extremely seriously, both in response to the allegations, but also in looking at our own processes. And as I hope we can demonstrate, we do feel that there is no evidence of the allegations made against us that's come before you. But I do want to say before I get into the detail that, we are very open to any guidance or advice that the panel may have at the end of this inquiry on how these processes can be improved. These are very complex matters, and so while we are very confident that we stand, free of the allegations made, we are not confident that our processes are perfect, and I did want to start with that comment. Mr. Chair, we do have slides. I'm going to go through them relatively quickly. I wanted to start just making a point to the panel about what we're trying to do here. We have provided the panel with extensive submissions, and the purpose of this is to provide some context for those submissions and for our activities in relation to fraud and forensic work. We also want to respond directly to Dr. Kimi's findings and show results of our own analysis. And obviously, we would like, if there's time, to highlight some of the responses to the complaints that have been put forward before you. On the next slide, we simply list our previous submissions for the sake of documentation. And then, Mr. Chair, on slides 4, 5, 6, and 7, we summarize the key points that we make throughout the presentation. Unless you wish me to, Mr. Chair, I would suggest not going through these now. I will make each point as we go. We did want to give the panel the benefit of this, if you like, executive summary, but I will make each of these points as we go, and I thought to save time, I would get directly into the agenda, which begins on our page 8, if that's okay with you.
Indeed.
Thanks. So starting then on page 8, the first point is some background context on medical schemes and administrators. I'm on page 9. I'm aware by now, Mr. Chair and members of the panel, that a lot of this will be familiar to you. Please indulge us if we do rehearse some things that you're aware of. But we did feel it's critical to start our testimony out by reminding the panel that medical schemes are simply an aggregate of individual citizens, members of society, and members of the medical scheme. They operate on a non-profit basis. They play a crucial social role for the proportion of the population fortunate enough to belong to a medical scheme, in that they pool risk between the young and the healthy, and between the young and the old, and the healthy and the sick. And they must always maintain a balance between the premiums they collect and the claims that they pay out. So our role is, in our fiduciary role, both the trustees and the principal officer and her team, and us as the administrator of medical schemes, is to safeguard that pool of funds and the members and the members' interests. And in our view, that is fundamentally the purview and the intent of the Medical Schemes Act. That's the role of the trustees of medical schemes and ourselves as administrators. And it is we are not here, to primarily protect the interests of suppliers of medical schemes. Of course, those must be treated fairly, consistently with the law, respected for the huge value they provide. But the primary duty of schemes, their trustees, and their administrators is to protect the interests of members. And that's our understanding.
I mean, you would accept, of course, that there is not a necessary distinction between the interests of members and the interests of the suppliers of services. One of the testimonies we had was a doctor from East London who came with, I think, 10 of her patients, who explained the difficulties they had in obtaining alternative medical assistance because a medical scheme had terminated and put her on direct payments, and had recommended to them that they should find an alternative doctor. So it seems that although the schemes like telling us that their primary responsibility is to members and not medical practitioners, sometimes it is hard to draw the distinction.
Mr. Chair, I completely agree that on many occasions it's hard to draw the distinction, and one would hope that in the overwhelming majority of situations, the interests of a health practitioner and his or her patient are fully aligned. But I think you would also accept that there are situations where their interests are not aligned. So where a practitioner is defrauding a medical scheme or otherwise claiming in an untoward manner, at that point, the interests are diametrically opposed. And so that is really the essence of what I think we're talking about in this inquiry. But on other general matters, I do agree with you. As a last matter of background, I think
Dr. Moonberg, just on that point, I think in one of your slides, and do correct me if I'm wrong, but it struck me when I read it last night, that you accepted that there are instances where doctors might be acting, let's say, unethically, but are in the interests of their patient. I can't remember the exact example in the slide, but it was something like, and I think it came actually under the expert report, but you said something like, and perhaps you can remind me because you will be more familiar with the slides, but doctors might, let's say, bend the ethical rules to benefit poorer patients.
Yes. So I think that is a critical point. We refer to it as a potential environmental factor that may explain some of the outcomes.
Leaving aside how it was used to explain the particular issue, but it does seem that you accept that there are instances, even where there is so-called unethical behavior, where there might be some alignment between the doctors and the patient?
There may be, but I do want to make the point very clearly, Advocate Williams, that we don't believe that conduct can ever be condoned.
Yes, and you did make that point in
Yeah.
your slide.
Yeah. You know, so this is a situation, I think, where a practitioner, we're trying to, I suppose, put ourselves in the mind of that practitioner or their shoes and to understand what might be in their mind, that they're not seeking to self-enrich, and they're seeking to help a patient. And so there's some humanity in that. Nonetheless, it can be illegal behavior or otherwise inappropriate behavior that the medical scheme should not condone or support.
Before you move on to your next slide, and this is slightly unrelated to the chair's questions and my follow-up question, but can we just get a sense of the difference in size between Discovery Health and the medical scheme? Because you're making submissions in relation to the scheme, but you're, of course, also making submissions in relation to the administrator.
Yes.
So could you give some sense of that?
I am going to cover that, Advocate Williams, in a little bit of detail later, but I think just to make the point now to answer you. Discovery Health is an administrator of 19 different medical schemes, of which one, our largest client, is the Discovery Health Medical Scheme, represented here by the acting principal officer. But we also have contracts to do the administration for 18 other medical schemes. Those are so-called restricted or closed schemes. They would typically be linked to one employer or an industry. So a university may have a medical scheme, as an example, or a large employer group. So we have 19 different clients. We conduct all of the work based on formal contracts, as we point out in the slides and our submissions. But I'm not sure I understand your question exactly when you say size.
Well,
what do you mean by
let's say
size?
size by employee
Okay.
between you and the
Yes.
medical scheme.
There's a vast difference in size. One of the there are two modes by which medical schemes operate, contemplated in the Medical Schemes Act. A small number of schemes self-administer. In other words, they act as the medical scheme, and they also employ themselves the full gamut of employees to carry out the administration. That's the minority mode in the industry. The majority mode, which you see in our case, is the medical scheme itself has a small number of employees, really to carry out oversight responsibilities of the contract, and the medical scheme outsources essentially all of the day-to-day operations and functions. This is very similar to a pension fund or a provident fund that has a board of trustees, possibly just one principal officer, and then all of the work is outsourced to a pension fund administrator. It's a very similar model. So,
What is the difference in size by employee between Discovery Health and Discovery Medical Scheme? That's really the question.
I can give you the exact thing. I just wanted to explain why there's a vast difference in size. Discovery Health has over 4,400 employees working for those 19 medical schemes. And the principal officer will correct me if I'm not mistaken, 8 employees in your office?
We've got 12 employees.
12 employees. So, and that disproportion is because the one role is governance, as the acting principal officer will explain, and our role is to execute a very large volume of transactions on a daily basis. If I can then just finish on slide 9, Mr. Chair.
Sorry, Dr.
Yeah,
Brumberg,
yeah.
and Discovery Health has a contract with the scheme, with Discovery Health Medical Scheme.
Yes, we have separate contracts with each of the 19 clients. Yeah.
And that contract would set out the fee structure for Discovery Health.
Yes, it sets out all of the obligations of Discovery Health in great detail, with detailed service level agreements in relation to the various obligations, and it also sets out the fee structure. Yeah.
Would you be willing to provide that to the panel?
I think it's these are. I think we can, provided it's confidential, retained
Yes.
confidentially. These contracts are highly regulated by the Council for Medical Schemes. They're reviewed annually, as are any fee increases, etc. Yes, certainly.
Subject to confidentiality,
Yes.
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 Thank you.
Thank you. You may proceed.
Thanks. I wanted to make one last point on slide 9, Mr. Chair, which is that a very substantial challenge for all medical schemes in this country today is high and rising medical inflation. And so a very significant part of our duty as the administrator is to assist medical schemes in managing the rising medical inflation, because as will be obvious to you, when claims costs increase, premiums have to increase, and you'll be well aware, you are all members of medical schemes yourselves, I presume, that premiums are rising more rapidly than earnings and salaries on an annual basis. On slide 10, we illustrate the extent of the pooling of risk between the healthy and the sick on the left of the slide, and the young and the elderly. And you can see here this important social function that a medical scheme plays for those members who are on it. And this is a critical function we believe we need to maintain. I'm going to move to the next slide, which is slide 11. I have made the point that medical schemes are not for profit, that they're managed by boards of trustees. The trustees have to set the annual contributions each year to ensure that they're sufficient to meet the expected claims. One of the drivers of claims, it is only one, and it's not the most important one, but it is an important one, is fraud, waste, and abuse. And to the extent that, along with other drivers of claims, fraud, waste, and abuse are poorly managed, all other things being equal, claims inflation will increase faster, and premiums will have to increase faster. And we actually illustrate this to some extent on the next slide. What the next slide shows, Mr. Chairman, is the data from the last 9 years for the Discovery Health Medical Scheme of inflation. And if I could ask you to cast your eye on slide 12 to the far right, this is the average annual inflation of claims per year for the last 8 years, 10.9%. If you now move to the left, and I won't bother you with too much detail, there are various drivers of inflation. CPI, actual underlying consumer inflation itself, is an important driver because the tariffs paid to doctors, hospitals, and others typically goes up by a little bit above CPI every year. Then we have factors that I think are not relevant from your perspective on both the demand and the supply side of healthcare. But if you look in the middle of the slide, in the supply side utilization column, you will see that our estimate is that the recoveries that we make as a result of our fraud and forensic activities and what we call the halo effect of those, and I can define that if you like, reduces the potential claims inflation on average by 1.5% a year over the last 8 years. So if we had turned off these activities completely in 2010, we would have had 8 years of further inflation, and that in a compounded basis, as you will see a little later, would have meant that the contributions, the premiums paid by the average member of Discovery Health Medical Scheme today would be 14% higher than they would have been absent that activity. So this is a critical part of our work, and it's a critical element of the work of all medical schemes and administrators, which is why for us it is so critical to persuade you that your findings should not end up hampering the ability of schemes and their administrators to tackle genuine fraud and abuse and to protect the members of schemes in so doing.
So 1.5%, is that FWA or fraud to the exclusion of waste and abuse?
No, I think it is almost exclusively, in our case, fraud. There are very limited elements. The term waste and abuse is a fairly broad term. I will address issues like coding and so on in relation to regulations 5 and 6 in due course. I think for purpose of your question, Mr. Chair, you can regard this essentially as fraud.
What about overutilization, which is induced by fraud? Where does that account?
There are many other activities that we carry out to manage overutilization that is not counted in this 1.5% at all. We can account for that separately. That is both the demand side utilization increase you see here of 2.8 and the supply side of 2.5, those themselves would be higher each year in the absence of our other activities to control overutilization. But none of what we're talking about today and in our submissions relates to efforts to control overutilization. That is a far more subtle and more complex set of processes.
Just so I understand your terminology, over-servicing would be a supply-side utilization issue, presumably by a doctor.
Correct.
So is your
Correct.
submission that none of your fraud, waste, and abuse activities in any way touch upon over-servicing?
I wouldn't want to make such a strong statement, Advocate Williams. I mean, I think there's an element, there may be an element of over-servicing in some of them, but it would be the marginal component of the kind of activities we're talking about. So, you know, as you'll see when I provide data on the breakdown of cases we investigate and that we're presenting in here, these are far more, if you like, crude, for want of a better word, examples of fraud. These are billing for services not rendered, billing for items not supplied to patients, extending the duration of a consultation beyond what actually happened. That's not over-servicing. You know, over-servicing is a patient presents with back pain, and do they need to be admitted to hospital, or could that back pain be treated at home? And at the margin, that's what we mean by
That's why I was
over-servicing.
asking about hospitalization,
Yeah.
which has been presented to us in the past 2 days as a key driver of costs. Because it's very difficult sometimes to know what is the difference between overutilization, over-servicing, and fraud. A typical example, a patient goes to a doctor, and they say, I have a headache. A doctor says, go to hospital for 5 days. You know, I mean, the fact that they say you must go to hospital for 5 days might not appear to be fraudulent, but in the broad scheme of things, it's dishonest.
Well, Mr. Chair, it is complicated. Our default response to a doctor's clinical decision is always to respect that decision, unless there's very strong evidence that that doctor's clinical decision is based on the wrong evidence, or that there's no evidence to support that. But it is very difficult if you're in an office in Sandton to second-guess a doctor's clinical judgment. And so effectively none of the issues that we are engaging with you on today are related to doctors' clinical decisions. There may be some exceptions. I may be laying a trap for myself. I don't think so. You know, these are not clinical decisions, and I think you're entirely right. There'd be a very small number of examples where a doctor's recommendation to go to hospital would be fraud. I can give one example of that. There's a certain subset of our members have policies called hospital cash plans. That pays a patient a cash sum per day, say 1,000 Rand or 5,000 Rand, after they've been admitted for more than 3 days or 5 days. And we have identified and dealt with syndicates where you have colluding doctors and patients, and the doctors arranging a long admission for no good reason in order for the patient to claim from their cash plan insurer, get a lump sum paid, and share that with the doctor. So that's a known example of fraud leading to unwarranted hospital admission. But my submission to you is that that would be at the margin. Your average hospital admission is either warranted, it may be a little bit unnecessary, but that's not fraud. That may be an element of over-servicing, but that's a different matter. If I can then move on past 13, where we want to share with you, Mr. Chair, some background on fraud, waste, and abuse. On slide 14, we make the point, I think you'll be familiar with this now, that the CMS itself has recognized the importance of this issue. It held an inaugural summit last year and issued a charter. It defined fraud and waste and abuse in that charter. I won't take your time to go through those. We do make the point at the bottom of slide 14 that fraud and the waste and abuse is not only a health practitioner issue. We recognize that the remit of this panel is mainly focused on health practitioners. But our data shows that only 29% of proven fraud, waste, and abuse in our environment actually arises from the activities of health practitioners. And the balance comes from members, and more than a third comes from corporate providers, including hospitals. So, Mr. Chair, you made the point. Hospitals are a big driver of cost. They're also a source of fraud and other billing irregularities, and we work as hard on those as we do on individual sources of fraud. So I think it's very important to understand that there is that balance. On slide 15, there's a little bit of data about the extent of fraud, waste, and abuse, both globally.
Sorry to interrupt.
Sorry,
Before you
yeah.
move on, in relation to your activities to address fraud, waste, and abuse with hospitals and corporate providers, are you still making use of Section 59.3?
Yes, we do. So certainly, and I could give you different kinds of examples. So there are certain things where we don't have to make use of 59.3. I'll give you a direct example. Certain kinds of codes are agreed in the industry that should not be billed by a hospital. I'll give you a concrete example. The drapes that are used on a patient to ensure sterility during a surgery are by agreement, formal agreement in the industry, should not be charged because they're included in the billing per minute in theatre. For whatever reason, some hospitals from time to time will include that code in a hospital claim. Now, a hospital claim, remember, could include 50 pages and hundreds or thousands of claims lines. So one of those lines arrives, and we're receiving, I'm not sure of the exact number, but probably tens of thousands of hospital claims a day. One of those claims, or several, will arrive with that incorrect code on it, and it should not be paid for. What would happen in that case is our claim system will automatically identify that. It will pay the claim. It will set up the claim for payment, which typically would go through the next day. The following morning, a team of ours would receive a report that those claims from that hospital need to be deducted from the claims run, and it will be pulled back. So in that case, there's no need to actually invoke 59.3 because actually the amount was withdrawn before it was paid. However, there are examples with corporate providers where a payment was made, and after the fact, often long after that, we identify a fraud that may be either directly as a result of the hospital or the hospital and the doctor, and we may need then, having paid the amount months ago, to go back and reclaim that invoking 59.3. So yes, I think the answer is both. If I can then move to slide 15, this is just some data. I think it's important to point out to the panel that anybody who confidently estimates the amount of fraud and waste and abuse in a healthcare system, wherever they are, is deluding themselves. These are guesses. When we think about 3% as the lower range, that comes from some published data from some reasonably respectable literature in international medical journals, and so and from the US and other systems. But suffice to say that it's a significant problem, and there's no science to the estimates. On slide 16, we simply make the point that there's enough legitimate reasons driving the pressure on affordability of medical schemes. Populations are aging, chronic disease and cancer are increasing. There are new technologies all the time that are very expensive, and so even without fraud, waste, and abuse, globally, healthcare systems are experiencing very high inflation. And so when you add to it this additional element, it does create the risk of adding to the unsustainability. And that creates the obligation on schemes and administrators to protect members' funds. And in our view, the provisions of the Act, its regulations, the rules of all of our medical scheme clients, and the contracts we have with health practitioners confer on us and our clients the powers to do what we do in auditing, investigating, and recovering funds where fraud, waste, or abuse have taken place. So We will obviously get into a lot more detail on that, but that is our general view, that our conduct is empowered by those various statutes and contracts.
Dr. Brumberg, when you refer to practitioner contracts, are you talking about DSP providers? How would you have contracts with the practitioners?
Yeah, so there are, Advocate Hassim, there are different kinds of contracts with providers. I think it's important to state that our understanding, and we believe this is clear in the law and in the rules of the schemes, is that the primary contract in the medical scheme environment is between the scheme and its member, and between the patient, the member, and the doctor. Those are the two primary contracts. Overlying those, there are certain arrangements between different medical schemes and different practitioners. And I'd like to distinguish here for you between DSP contracts and what we in Discovery Health refer to as payment arrangements. They're both contracts, but they're not the same. DSP contract is where we have agreed with a provider to act as a designated service provider. That has a very specific meaning in terms of the Act, because that's a provider who's providing services that are classified as part of treating prescribed minimum benefits. And so we use DSP in a specific way. The second category would be payment arrangements. And this is where, regardless of whether a doctor is a DSP or not, we have agreed with her to say, our primary contract is the member. We would typically pay the member. However, if you're willing to agree to certain conditions, we will pay you directly. And that is a payment arrangement. A key condition there is that there's a maximum amount charged for a particular service. And the key agreement there is that the practitioner will not balance bill, will not charge anything more to her patient. And that is a critical function for us, because it means that between 80 and 90% of all practitioners, depending on the discipline, in the Discovery Health environment, agree to those payment arrangements, and that provides enormous protection for members, because they know that if they go to any one of those on a payment arrangement, they know what they will pay, and there will be no additional payment. And in fact, the medical scheme will settle their bill.
Sorry, did you say 80 to 90% of practitioners?
Advocate Hassim, the numbers vary. On average, if we include specialists and allied health practitioners and GPs, I may stand under correction, but as far as I'm aware, approximately 90% or almost 90% of all visits take place in terms of with a practitioner who's on a payment arrangement. So I'm distinguishing here between visits and the number of practitioners, because that may not be identical. You may have much busier practitioners. I think that depending on the discipline you look at, the number of practitioners, so if you looked at GPs as a category, et cetera, it would vary between about 80% and 90% of the practitioners, but on average 90% of all visits take place with a practitioner in a payment arrangement.
I have searched all the papers that I have, and I can't find a copy of that contract. Could you point me to it if it is there?
Have we submitted contracts, a DPA contract? I'm not sure if we've submitted them. We're very willing to submit them.
That would be very useful,
Yes,
because
yeah.
I think it's quite important to the discovery as opposed to other schemes,
Yeah.
what these contracts are with practitioners,
Certainly,
because
yeah.
it's unusual.
Yeah, they're very simple. They are entered into on an any willing provider basis, in the sense that any provider who wishes to participate can, provided they meet certain criteria. The criteria in some cases are as simple as you're qualified, you're registered, and you're willing to accept the payment terms. There are also increasingly quality-related requirements. You have the right equipment in your practice, you have the right qualifications, you have the right staff, and so on. Practitioners can...
Can you just tell me, do you have the racial breakdown of people who are on the DSP for Discovery?
I don't believe that we have that to hand, Mr.
No,
Chair.
but it's something that can be provided.
It could. We'd have to do
And
the
then
analysis.
the racial breakdown of those people on payment arrangements.
Yes, we have that.
Thank you.
Just a further request on this point. I assume you will have contracts, payment arrangement contracts and DSP contracts, which have been entered into over a number of years,
Exactly.
and they might have changed over the years. Can you be sure to just give us a proper selection so we can see how they might have differ between year and year, or if they're the same, fine?
Certainly, we'll do our very best, and if what we provide is not satisfactory, please do let us know.
The absolute numbers beyond the 80 and 20%. I mean, is DSP 10% or 20%?
Sorry,
Let's say 10%, but what are the absolute numbers?
of practitioners. Again, I'd speak under correction. I mean, we receive claims from a total of 35,000 billing practices in the country. I think the absolute numbers, depending on whether you're talking about GPs or specialists, would vary. In total, probably around 7,000 or 8,000 if you added them together with allied practitioners. But Mr. Chair, can we provide you the accurate answer to that?
Thank you.
That'll be easy to do. I just don't have it handy.
May I just ask one more question on this point? Both in relation to the DSP contracts and the payment arrangement contracts, presumably the doctor is agreeing a form of a fee cap. Can you answer the question into the mic? Sorry, for the record.
So yes, the doctor is agreeing a maximum fee per service. Yes.
So would it be fair to or say that doctors who are more financially cash-strapped would accept those contracts?
I think yes, and I'd go on to say it's actually more important not so much whether they're cash-strapped. I think a more important determinant would be the economic status of the majority of their patients. So if I can give you an example, in a relatively wealthy socioeconomic area, Sandton would be an example, and you could find similar suburbs in other provinces, a higher proportion of a doctor's patients in that area would be able to afford a co-payment. That will lead the doctors thinking to say, I don't have to accept this fee cap because I want to charge more. I will then take the credit risk that a Discovery Health medical scheme client will pay the member their portion. I will collect the amount from the member. So to give you an example, a typical doctor may charge, say, 500 Rand more than, or I'm just making up numbers, than the Discovery Health rate for a service. That doctor's making a calculus that says, on average, I can make 500 Rand more per visit if I charge higher than the Discovery rate, and that will compensate me for the credit risk where some of my patients may never pay me, which is a reality as well. So you're right, but I think it's more driven by the socioeconomics of the patient base.
Thank you.
Sorry, Dr. Mrubube, in that example, would the doctor not require that the patient pays the doctor directly and then claim reimbursement from the scheme, and then the scheme would reimburse to the amount of the benefit?
That's correct. There is still some credit risk, Advocate Hassim, because you should bear in mind that when a patient's admitted to hospital, which is a high proportion of a typical specialist's income, there's no opportunity to collect upfront. That's different if you visit a specialist yourself. You often, a specialist who's not in a payment arrangement, you will, and you may have had this experience, you'll be asked to pay upfront with a credit card or to pay a bill, let's say after you come from hospital. Because we pay our members very quickly, unless you are literally paying upfront for an outpatient visit, if you get a bill from your specialist after discharge from hospital, you would have been paid by Discovery before you have to settle the specialist bill. But you do have to settle the bill, and you will have heard complaints from certain doctors that the scheme has paid the patient, but the patient never pays them. And that is a concern that certain doctors have. Mr. Chair, if I could just respond back on your question about whether we have race information on payment arrangements. The accurate answer is we don't keep race data on practitioners as we've maintained from our very first submission. What we will do, to answer your question, is use Dr. Kimi's analysis, supplemented by our own, and apply that against the database or sample of the database and provide you, we think, as accurate an estimate as you believe either Dr. Kimi's or our name analysis can represent.
Well, I mean, the DSPs would be more exact than the payment arrangements because those are contracts signed in advance.
Now, that's true. They both are contracts signed in advance, but the point is that we don't, if we have a database of all of those thousands of contracts, we don't keep a race indicator. We've got a name and a practice number, but nobody's ever asked us until this process how many are black or non-black. And
can you just, yes, no, that's fine. I'm sure you say that you will produce it
we
by
will produce it
replicating
using the approaches that have emerged from this inquiry.
All right, that's fine. Thank you.
I now want to turn to slide 18, please, and to talk about the obligations and duties of schemes and administrators in relation to fraud, waste, and abuse. I think the panel now well understands that schemes have a requirement, an obligation, to protect the interests of beneficiaries and to preserve scheme funds and to take appropriate measures to deal with fraud, waste, and abuse. The Act requires that, the Medical Schemes Act. So does the Financial Institutions Act 28. So does the King 4 report, and of course common law creates those obligations as well. There are also obligations on schemes and administrators arising from our regulator, the Council for Medical Schemes. The CMS requires, in terms of our accreditation, that administrators demonstrate and maintain effective forensic oversight over claims. The CMS expressly recognizes the lawfulness of administrators having detection measures for fraud, waste, and abuse in place. The CMS Circular 35 of 2019 placed even greater emphasis than in the past on such fraud detection. And I've referred also to the obligations arising from the FWA Charter published by the Council. And so in terms of our accreditation as an administrator, and in terms of our contracts with our 19 clients, we have clear fiduciary duties to invest and to act effectively to detect, investigate, and recover funds where we believe they've been inappropriately paid out. I now would like to turn to slide 21, which I think addresses in a little more detail some of your questions about Discovery Health itself. As I mentioned, we are an accredited administrator. We have 19 separate schemes as clients. That gives a total of 3.5 million people under the administration of Discovery Health through these 19 clients. And we, as I answered to Advocate Hassim, we have separate contracts with the Board of Trustees of each scheme, and we operate under that formal contract in each case. I'm turning now to 22. Our contractual role, as I outlined before, is to manage literally all of the operational and administrative affairs of our clients, including FWA investigation and recovery. As we
just explain this, I mean, you see, so Discovery Health, the administrator, with 4,400 employees, how does it really account to the Discovery Medical Scheme with 12 people?
Yeah, so the 12 people are, Mr. Chair, are the employees in the office of the scheme. It also has a board of trustees, and we account to both of those entities. And the way we do that is through highly structured governance arrangements. We provide an agreed number of reports. Those are typically monthly, quarterly, and annually on a very wide range of the functions that we perform, so including on fraud, waste, and abuse. So there are written reports. We attend every meeting of the Board of Trustees and provide reports on our activities. We attend meetings of subcommittees of the board. So there are very formal, well-structured governance arrangements in place. And in our opinion, and this has been frequently reviewed externally by the trustees themselves, the governance and oversight functions of all of our client schemes are performed very well. The trustees take their fiduciary duties extremely seriously. they understand their obligations, and they provide very significant oversight over our activities. So it is true that there's an imbalance in personnel, but that is compensated for by highly structured governance arrangements and reporting. And it's not dissimilar, as I said, from other arrangements in our economy and globally with pension funds, provident funds, insurance funds, and so on.
Tell me, how many members are in the Board of Trustees?
The board is, as far as I know, on the Discovery of Medical Scheme Board, there are 7 trustees.
That's correct.
Correct.
How many times a year do they meet?
They meet, as far as I know, 6 times a year.
Yes, at least that's a minimum of 6 times. It can be more depending on ensuing issues within that fiscal year.
Thank you. Yes, I mean, I'm struggling to understand how this happens on a practical basis. I mean, I see that you submit reports, etc., but it seems to me that most of the work is really done by the administrator.
Mr. Chair, that is correct. And that is, as I said, the accepted mode, one of the 2 accepted modes by which medical schemes operate in our country, and they're envisaged by the Medical Schemes Act. Where required, beyond reporting and beyond meetings with subcommittees and the committees and the trustee board itself, the scheme becomes actively involved in certain important functions. I'll give you an example in the case of fraud, waste, and abuse. I'll come later to showing you data on where practice becomes blocked permanently for payment in certain extreme situations. Any decision to block a practice is made by a committee that comprises representatives of the medical scheme as well as ourselves. Similarly, this is not to do with fraud, waste, and abuse. On a weekly basis, we have a committee comprising the medical scheme and ourselves that adjudicates and investigates very complex funding cases where there's a dispute, where there's a very expensive new medication, etc. So although you are correct that the vast majority of operational activities are undertaken by the administrator, the scheme involves itself daily in the most escalated and critical of those decisions.
Not only is the vast amount of work performed at the administrator level, the vast number of decisions are taken by the administrator.
That's correct, Mr. Chair, and those decisions are made under the rubric of very careful mandates and policies and procedures that are defined by the medical scheme client. So on any one of these, including fraud, waste, and abuse, including any other issues, not only do we have a contract with associated service level agreements and metrics, but the scheme will often have a policy on a certain thing, and that forms part of our mandate. So again, we do make most of the decisions, but within the rubric of a governance mandate, and the scheme's role, as we understand it, is to ensure, through supervision, through oversight, through meetings, through reports, that we are adhering to the mandate they've given us.
How many people are in the FWA division?
I have the numbers
versus
here.
I just want a comparison between
Yes.
yours and the schemes,
Yes.
so that I understand how this.
We have a total of 44 investigators, Mr. Chair, and auditors, and a further 55 experts who work in the FWA activity on a part-time basis. So roughly 100 people involved either full-time or part-time in FWA activities.
And on the scheme side?
The scheme side, I think the whole office, and perhaps my colleague, the acting PO, will answer this. As far as my experience is concerned, many of the senior staff from the office, as well as a particular subcommittee, the Stakeholder Relations Committee of the board, are involved. So perhaps, Charlotte, you can give numbers there.
Thank you, Johnny. From a scheme perspective, Chair, just to also reiterate the fact that we do have the Board of Trustees, which has the 7 members. That Board of Trustees is supported by subcommittees who also on them have independent members to supplement some of the skills shortage that might exist on the Board of Trustees. So we do have 7 independent committee members. Some of them are necessitated by the Medical Schemes Act from an independence perspective when it comes particularly to the audit committee. There must be at least 3 independent committee members on that side. But specifically to this matter, the fraud, waste and abuse activities performed by Discovery Health are reported through to the risk committee, which has both independent
I'm
members
trying to
and
understand.
trustees.
I know that they have
Yes.
100 employees.
Yeah,
How
we-
many employees do you have monitoring this 100?
We have 3 members. Yeah, we have 3 members of our executive committee who monitor not the people on the discovery side, but rather the activities that are performed that relate directly to the scheme.
Yes, I mean, I put this to Dr. Brumberg, that it seems to me that the work is performed at administration level and the decisions are taken at administration level, and he candidly confirms that that is correct, although he justifies it by reference to policies and oversight. Would you also accept that in reality, the administration work in relation to FWA is just performed by the administrator, and the decisions are also made by the administrator?
Chairperson, when it comes to the decisions that are made, most of the decisions are made on the administrator side by way of the various contractual arrangements in place and also the specific actions that are involved in there. I must also state that the policies that are in place relating to fraud, waste and abuse, which Discovery Health has put in place. Sorry. Some of the policies relating to fraud, waste and abuse that are in place on the Discovery Health side do come through to the scheme for the scheme also to have sight of them and make commentary where the scheme believes that the commentary is required. Over and above that, the scheme does get involved in some of the blocks that are done that are recommended by Discovery Health. So where there is going to be a stop to the direct payment as a consequence of fraud-related investigations and the outcomes of those. The scheme, and I think Dr. Brumberg did mention the fact that those decisions are not made by the administrator in isolation of the scheme, but the scheme is part and parcel of making that decision and interrogating the factors applicable to that specific case or activity.
I accept that. I
Yes.
think Dr. Brumberg's position is that there are 2 categories of decisions where they specifically seek your assent through a committee system. The one is complex investigations. The other is where a decision is to be made to block someone permanently. But we know those are exceptions. The vast number of decisions do not relate to those. And those are really made by the administrator.
That is correct.
If I may continue, Mr. Chair, just to repeat my point that that is the mode anticipated by the Medical Schemes Act of operation of the vast majority of medical schemes, and it's not unique to Discovery Health and its clients. You'll find this pattern throughout the industry, with the exception, as I mentioned before, of a self-administered scheme, of which there are some who conduct these themselves, all of these activities themselves.
Yes, no, that's fine, Dr. Brumberg. You see, the point is no one is trying to trap anyone. We're just having a frank conversation. Is that the Act imposes the obligations on the scheme. In reality, the scheme is incapable of discharging these obligations. It's got 3 people, you have 100 people. It's got 12 people, you have 4,000 people. And that is why the practical effect is that most of this is just really just outsourced to you.
I think that's correct, Mr. Chair. It is so in our view, and as I said, the regulator clearly endorses this view because it's been in practice for decades. That the outsourcing is a legitimate mechanism by which the scheme and its trustees discharges those obligations. I think it's critical to emphasize here the difference between operational obligations and oversight obligations. And I think what I've tried to confirm in responding to you is that the administrator carries out the operational duties, and the obligations on the scheme office and the trustees are to be diligent and rigorous about oversight, and we believe that system works very well in our environment and similarly for other medical schemes.
Has the scheme ever overridden any decisions that are made by the administrator, or altered decisions that are made by the administrator?
In the weekly meetings that Dr. Broomberg spoke to, where certain recommendations have been made, there have been instances where the scheme has not been in agreement with the proposal being made by the administrator. And in those instances, then the default position is to comply with the wishes and the instruction of the scheme.
If I can add to that, Advocate Hasim, we attempt wherever we can in those committees to reach consensus, and the scheme's voice is very loud, as you'd expect, and very highly respected. But, of course, in the final analysis, the scheme's view will always carry.
I need to understand the evidence, because Dr. Broomberg said daily meetings. You said weekly meetings. Which is it?
I can perhaps clarify, Advocate Williams. I referred to weekly meetings. If I said daily, it was an error. Those are meetings that are not linked to FWA. They are meetings, I was referring to complex cases, difficult judgment calls, and there we have a combined forum that meets every week. The committee that would meet to decide on the blocking of a practice permanent would be an ad hoc committee. It would not meet frequently. That's a very unusual decision, as I'll show you now. Cumulatively, I think 0.7% of practices are blocked at any point in time, 0.7%.
And even in those decisions, the first assessment as to whether or not a practice deserves to be blocked is made by the administrator.
That's correct.
It comes to the scheme as a recommendation.
Yes, that's
and
correct.
The fact of the matter is that it is impossible for the scheme to exercise independent judgment because they just do not have the raw data that you've collected. What they see is the recommendation.
I think that what matters is whether they believe that the administrator to which they have outsourced these roles is performing its duty diligently, that it is not biased, that it does not have any perverse incentives, that there are no reasons why the advice would not be sound. There are also many situations, not necessarily in FWA, but including in FWA, where the scheme has external reviews performed in order to ensure that our policies, procedures, etc., are meeting applicable standards and regulation.
I accept that they have to trust you. That's why they've contracted you. What I'm trying to test is the robustness of the structure. That the structure is such that the power is really held by the administrator, and most of the work is done by the administrator, and that the power of the scheme, although it exists in the Act, it's really illusory in practice.
Mr. Chair, I respectfully disagree. The ultimate power lies with the trustees. They are able to terminate their contract with the administrator by law in no more than 90 days. They have ultimate decision-making authority over every decision. You're completely correct that day to day, the design of the contract is such that operational power lies with the administrator, but governance power lies completely with the schemes. And that is how the Medical Schemes Act is designed. So I think to the extent that you're expressing an opinion on an imbalance, I think your issue is with the Act, as opposed to how it's implemented.
Yes, I think the Act is quite clear in terms of imposing the primary obligation on the scheme. The rest of it is that the scheme then decides that they will give most of these judgment calls to the administrator in circumstances where they must be aware that if you have 3 employees overseeing 100 employees, it's just practically impossible. If you have 12 employees overseeing 4,000 employees, it's just impossible. I'm questioning that structure to say whether or not that structure in fact complies with what the Act envisages, because the Act doesn't impose obligations on an administrator, it imposes them on the scheme.
Again, Mr. Chair, not to get into too much of a debate, this is perhaps a difference of opinion, but I do respectfully disagree. I think that throughout society, we have examples of governance arrangements where small groups are entrusted and obligated to oversee very large groups of people, and they do so through governance arrangements and suitable reporting. The Discovery Limited Board of Directors is a small group, overseeing 10,000 employees. They are very far from the day-to-day operations. They entrust the management team to carry out and take most decisions, but they execute their fiduciaries under the Companies Act and other law by insisting on regular reporting, by interrogating those reports, by having external auditors, internal auditors. So I submit respectfully that the governance arrangements in schemes are no different to many other parts of our economy and the international economy. And it depends on how faithfully and diligently the governance arrangements are set up and implemented.
Thank you. Well, we have a duty to put this to you for your comment. So,
Yes, thank you.
Feel free to engage as robustly as you feel like.
Yeah. So, Mr. Chair, if I may carry on then, I'm still on slide 22. I did want to make the point, because there have been allegations to this effect by some of the complainants in front of you, that somehow administrators benefit unduly from their fraud, waste, and abuse activities. And I did want to take a minute or two to clarify that for the panel. I think the first point to make is that Discovery Health, and this is true of any medical scheme administrator, is paid a fixed fee per member per month. And that fee does not vary linked to what we do from an FWA point of view, nor to whether claims are paid or not. So our interests are fully aligned with the medical scheme client, because the more effective we are in managing claims costs, the better the medical scheme will be looking after its members. The only area of non-alignment is the fee itself, and that is a commercial negotiation that typically occurs on a 3 or 5 year cycle with annual increments that are typically agreed in advance.
No, I think that it goes beyond look, there is the general problem that administrators are improperly incentivized because their remuneration is linked to recoveries. That's the one accusation that you are responding to. But the other is an internal one, which is how do you pay your investigators?
Okay, thank you. So I think just to then again re-emphasize in response to your first question, we have absolutely no financial interest in the FWA recoveries. We spend money on them. The costs of those 55 full-time and 44 part-time people are high. That's part of our obligation. But 100% of the funds recovered go back to the medical scheme and or the members when the funds are paid back to a medical savings account. The second thing is that we pay our...
we also don't have those figures about what actually you've recovered and paid to the scheme.
So we have given, and I'll go through them later in the thing, the total amounts that are recovered. I can tell you that we can happily provide whatever reports you want on what's been paid back, but these, the accounts and the payments are very strictly audited. This is if you in the instance of the Discovery Health Medical Scheme, this is a scheme that's collecting premiums and paying claims and expenses of upwards of 60 billion rand a year. It is intensively audited both internally and externally, and every cent is accounted for. So there can be no question that every cent is paid back. I think it's important to point out to the panel that the funds actually never are in an account of Discovery Health at any time. The funds are always held in accounts owned by the medical scheme. So the funds are in the scheme's account. They would be paid to a provider. When they are recovered, they will come back to the scheme's account immediately. Those funds never touch an account under the control of Discovery Health as an entity. So, but to the extent, Mr. Chair, that you require documentation, please specify that and we'll supply anything that's required.
Yes, we will come back to it because we are also interested in what happens when the amount reaches the account of the scheme. Because if you are tracing a specific amount, whether or not it ever reaches the patient who has been defrauded or not, what happens, maybe it goes to the general pool. But I just don't want to leave you on this question about how do you pay your investigators.
Right. So our investigators are paid fixed salaries. Some of them, from time to time, will be part of incentive schemes. We have broad and widely applicable management incentive scheme for the management team, and those management incentives are linked to performance. They are usually linked to the broad performance of a division, for example, the whole FWA division, and to the whole company, in this case, Discovery Health. There are no circumstances I'm aware of where an individual's pay who's working in the FWA area is linked to the amount that that individual recovers. So this is not a situation.
How do you measure the performance of the FWA division?
I think there would be many. There would be many metrics, and we could supply you with these in detail if you like. But there would be, broad issues like the number of cases that are being processed through the Raptor system, the turnaround time of cases, the quality of work and the number of errors that are performed. There will be annual targets, broadly for recoveries. That's an important way to encourage activity. But those targets are, not directly linked to the pay of any one individual in our fraud and forensics division.
What role do the annual targets play in the structure of remuneration?
I can't, to be honest, Mr. Chair, I don't have enough detail to answer that very accurately. I think that my guess, and we can confirm this in writing to you, is that the annual target would be one metric, one of several metrics that would result in an aggregate score for either an individual or the division. And there will never be an individual target linked to the pay of an individual. It would be the target for the whole division. I also wish to point out, Mr. Chair, that we've supplied those performance metrics to Dr. Kinney. So we have supplied them to you.
No, see, what I'm asking is the money. Because I don't want a general matrix that doesn't help me to understand that the annual target for 2019 is R1 billion for recoveries. The factor that played was 40% of the overall remuneration structure. The consequence was that each manager, because they met and exceeded the target, got 10% more than they would have.
Right, so I think we can provide you, if I sat here and gave you those numbers, firstly, the targets are definitely less than R1 billion. I can't tell you what percentage of the metrics of individuals. You use the hypothetical 40. I don't know that number. We'll get it for you, and so on. But I do have to say that regardless of that number, there are such detailed policies, procedures, and governance arrangements in place that I can confidently tell you that no case is prosecuted and no recovery is made that is unreasonable and that is driven by the individual financial incentive of any employee of Discovery Health. I can very confidently make that statement.
Can you tell us, what the target is based on?
It typically is based on what's historically been achieved. That would be the most important input. And then, if you like, what our managers would do is try and put, some kind of understanding of if last year the recovery was 550 million, for example, the total recovery, that would cover quite a wide range of sources. We know that claims inflation is going to go up by around 10%. So that would be an automatic increase of around 10%. And it would typically be that alone. The managers may say, let's see if we can kind of, identify additional frauds. Let's stretch the target a little bit to try and push our people to work harder and work smarter. But I think the science would simply be the inflation rate on last year's achievement.
That's why I don't follow your answer when you say that there is no one incentivized to reach a higher target if the managers prescribe the target, because it seems logical that if my employees know that this year's target is 100 million, everyone is going to try and reach the target because they know that it will play a role in the matrix, whether it is my hypothetical 40% or maybe 10%.
So I think if I can distinguish here, Mr. Chair, firstly, the senior managers, actually, if you think this through, their incentive should be to set a lower target, because then the whole division will beat the target easily, and everyone will get a nice big bonus. And that's always the dilemma of senior executives is, are my managers gaming the situation here by setting, in the jargon we would say by lowballing the target. So that's obviously a concern. We trust our managers in our forensic division to stretch themselves and everybody else. So I think I can agree with the direction of where you're going, which is that there's an element in the remuneration. I think it's a minority element. I don't have the exact numbers. That is linked to the overall performance of the overall team of 100 people. However, I do want to emphasize strongly that the governance and the care we take about how investigations are initiated, how they are prosecuted, and how the engagement and recoveries make is such that there can never be rogue behavior. You can never have an individual or even a division doing things that are unacceptable, unfair, or inappropriate because they're chasing a financial target. I have never seen that. It's just not how our business works, and there is no evidence that that's the case.
So the evidence from LCB Klink and Associates went directly to this point. I mean, I can't remember which of the witnesses, but she said that discovery analysts are trying to see how many they can catch out.
Yes.
So, I mean, we certainly have heard the experience from the provider's perspective, and we must take that seriously.
I agree that you must take that seriously. We did respond in writing, and I'll repeat the point here. We completely reject that allegation. There's no evidence was put forward. It's pure speculation. And we've countered that, Advocate Williams, I think, with very objective, concrete evidence. We've told you, and I'll repeat the point, that on average over the last several years, 53% of our investigations have arisen from tip-offs. These are external tip-offs, and we can demonstrate that. So that's not us seeing who we can catch out. That's typically members or colleagues or other people sending us an email or calling an anonymous tip-off line, and that leads to more than half. If my memory serves, in the last year, we're approaching 60% of all investigations were initiated from tip-offs. That's a rising trend. The 100% of the balance arise from the application of our statistical analysis, which identifies potential outliers. I will go into this in more detail. There is no space, there's not an inch of room in our environment for any individual or any policy that says, let's see who we can catch. That's just not the case. There's no evidence for that. We have objective evidence we provided you to counter that allegation.
So then why do you set annual targets for recoveries if they are as unimportant as you are trying to show us?
No, I don't think they're unimportant. I think they're not the major or even a major driver of the conduct of our staff. We do think it is an incentive for people to work faster, to work harder. Once cases, we have many more cases in our system than our teams can handle in a year. This case management system, so if we double the number of people, I think we double the number of cases. So having a target is clearly one of the impacts of that. Is people need to be encouraged to get cases completed, more quickly, not to dilly-dally, get the information they need, try and arrange meetings, etc. So there are reasons to set targets. Throughout our business, we have targets for our teams, and this forensic team has targets as well. But my critical point I'm trying to persuade you of is that does not lead to perverse behavior, and there's no evidence that it does.
I'm not sure I heard you earlier. You said there's not an inch of space for what in relation to your systems?
For subjectivity I was responding to LCB Klink's allegation via a client for subjectivity in relation to sort of seeing who we can catch out. There's just that phenomenon, there's no space for it because it's tip-offs and it's statistical analysis. And our teams are overwhelmed by the number of cases from those two sources. They can't manage them. So I don't see that any of our employees has a minute in his or her day to think about who am I going to catch out today. They're dealing with an overwhelming caseload that's come from two very objective pipelines.
But as I understand it, it's not correct that your system is entirely automated. there are manual interventions, and that you've engaged with our expert on quite significantly.
I'm trying to, I'm not sure I understand, what we're referring to here, I think I'm responding to the allegation from Elsabe Klink, that we see who we can catch out. I think please correct me if I'm understanding you wrong, that applies to the way that that cases are initiated for investigation. So when I'm addressing you now, I'm talking about how do cases arrive on the desk of the Discovery Health Forensics team? They come through only two channels. Not by somebody saying, who can I catch out today? They come from tip-offs, and every tip-off is investigated regardless of source, nature, etc. Every single one.
Is every statistical flag also investigated?
Every one that is flagged above a threshold goes into a pipeline. So every tip-off and every flag, just picture these two pipelines filling up a pool. That pool is always fuller than we can manage. We then have prioritization processes for those. I think we pointed out, I'll cover it in the slide later, that there are a number of prioritization factors. The fact that this was a tip-off is a very significant prioritization factor, so those would always pop up to the top. The second most important will be the source of the tip. If it's a member tip, that becomes very
Appreciate
important.
that in relation to the tip-offs,
Yeah.
that would be
Yes.
prioritized. I'm talking about those that are flagged
Right.
through
So the flags that come
analytics.
through the risk rating tool would then be picked up, would be prioritized through a third criteria, which is the value, the potential value at risk, and therefore, the importance of tackling this quickly, stopping any fraud and recovering any losses. Advocate Williams, have I answered your concern?
I mean, perhaps I can just take you to many pages I'm referring to, but the page I am referring to, I can take you to. It's in your bundle. These bundles are difficult to manage, I accept, but it's in an annexure to the expert report, and it's a note by Roseanne Harris, where she explains how the cases are allocated to the Raptor system, and it's pretty clear that it's done manually. I'll give you some time to find it, but
Yeah.
I mean, you would be familiar with this.
Do you have a page reference by any chance?
I'll find it for you.
Okay. Now, I think that once, I'll answer it before we find the page, but I think that's right. And this is a part of the answer I was giving to Advocate Hassim. So,
3394.
so Advocate Williams, they arise without manual intervention through these two sources. Once you have this pile of cases, as I said, there are 3 sets of criteria that are applied, and that will be manual. In other words, did this come from a tip-off or not? If it's a tip-off, particularly a member tip-off, that would immediately be accorded high priority. If it's a tip-off not from a member, that would be accorded second priority. If it came from the risk rating tool and it was high value, that would then go in. So of course there's manual, but there are criteria. You don't have somebody sitting there saying, let me find Dr. X because I don't like her, and I'm going to find this thing. They are working under policies and procedures which are overseen by their managers, and nobody has provided any evidence that we are acting subjectively in that. And our evidence...
As I understand it, is a manager who does this. So have a look at page 334. And I understand it, and please correct me if it's wrong, but it is a relatively senior manager who does this based on human judgment. And human judgment is your words. And again, in your words, the forensic team will analyze the scores from the RRT to identify providers that seem most suspicious.
Yes, but I can't actually see exactly what point you're referring to. Do you guys not have a paper there? I don't know what. Yes, so I think I think you're referring to 4.6 from my colleague Roseanne Harris. So I think that the risk rating tool is an objective tool. It puts out a risk score. When a practitioner or practice comes up above that score, it would be flagged. You would then have a pool of cases that are flagged above a score. And we've given you here 5 factors that would then be applied in an objective manner, not in the interest of seeing who we can catch out. Again, quoting Elsa B. Klink, by these 5 factors. One is, how much capacity do we have to investigate cases at this point in time? The second is...
Would you mind bearing with me, because I don't think we're on the same page.
Sorry, yeah.
Could you just tell me what page you are on?
So I'm on a page 35, 3394, my apologies, at point 4.6.
So that is our expert summary of what was recorded in the meeting. There is then a further response from Roseanne Harris, which
Which page
follows
is that,
that.
please?
I wish I could tell you a couple of pages later, but we'll get there. And again, it's at paragraph 4.
Okay, the number of cases to be included depends on the capacity. So that's, I think, confirms what your expert said. We then, we get a total risk score per provider, where higher score indicates higher risk. The cases are allocated to be worked on based on the total score. It is manual, and there's an element of human judgment. The team will analyze scores to identify providers that seem most suspicious. So they're using their judgment, they're using their experience. Can I remind you here that at this point they don't know who these providers are. They have a PCNS number. They're not seeing who they can catch out. They're receiving a dossier of cases that a statistical tool have flagged as high risk. They can't investigate everyone, so they're applying human judgment to say, based on what we've seen, these look higher value or more suspicious or more risky. Let's put them there first. That is not the same as let's see who we can catch out.
I suppose the point really was just to moderate your earlier claim that there is no scope for subjectivity. I mean, I think that's really the point that is being pushed, that it's clear on the evidence given by your own internal people that there is, in fact, scope for subjectivity. And that's not a bad thing, but it is just to moderate the claim that you made earlier.
Thanks. I do fully acknowledge that point, Mr. Chair. I do think, if I can just emphasize that, that exercise of human judgment is in the interest of applying scarce resource to the highest priority cases. We don't think there's any evidence of bias in that of any kind, either race or otherwise. And, the external review by the law firm, by H&M, did confirm that view, that they saw no bias in the way that the risk rating tool is applied and cases are selected.
Can I just complete the point about the composition of staff? So my understanding is you have 45, is it investigators? And then 55,
auditors, 44
investigators.
44 investigators
experts.
and auditors, yes.
Now, of those 44 investigators, what is the racial breakdown?
So I can give it to you. I do have, I asked my team for the total breakdown of the 100.
Yes, no, I understand,
Yeah.
but I think that certain decisions, depending on complexity, will then
Yes.
go to the experts.
Okay.
So I want to know, the people that interact with the doctors, are they black or white?
Okay. So of the whole forensic division, 58% are black. So of those 44 people, 58% are black.
So that's 44.
Yeah, 58%.
58%, yes. And then of the 55,
the subset of those that work in our analytics, 100% are black.
yes. No, of the 55 experts,
Yes.
so that's all 55 are black.
Yeah, no, I don't think that's the same as the whole forensic analytics team. But are they within the 44? Okay. So within the 55, Mr. Chair, we have a team that is specifically allocated to work on analytics of fraud.
No, I understand, but
They
I
are
want
all
to know
black.
the racial composition of the 55 experts.
Okay, so I think we'd have to get that for you, but I can confirm that there's a subset of those 55 whose full-time job is fraud analytics. They're all black.
Yes. And how many are these?
How many? 4 of those.
4
Yeah.
out of 55.
So the other
the
51
problem-
are working part-time.
No, I understand. The problem is that once you say 100% is black, it disguises the picture if it is 4 out of 55.
Yeah,
So that's
yeah.
why I need the total
We'll
55.
certainly give it to you. We're not trying to disguise anything.
Yeah.
We're very comfortable
Yeah.
that, you know, the overall team is a majority of black colleagues. And I think, and we can give you any other information you need.
Yes, no,
We'll
just
break
on
it down in
55.
that
Yes,
55. That's
that would be
fine.
helpful. Thank you.
Returning then to page 24, I have 2 slides here, which I won't go into detail, but they're on your record that I'd like to, you know, just make the point that Discovery Health is highly committed to transformation. The executive team that I built up in the 10 years I was chief executive is a majority black team. Our executive committee is over 60% black colleagues. Close to half of them are women. And I think I've made those points. So I'm going to take you directly now to slide 27 in the interest of time. So this is just an outline of the claims process. I'm going to go into, of the FWA process. I will go into a lot of detail on this in the forthcoming slides. We have gone through these numbers. On the next, which is page 28, I have made the point, but there is very strict and detailed set of governance arrangements and policies and review processes that govern our FWA activities. We have formal corporate policies. They are reviewed by both the Discovery Health Board, the Risk Subcommittee, and the Social and Ethics Subcommittee of the Discovery Group Board. Going back already to 2007, we began to commission external reviews of our fraud and forensic activities from external experts, usually legal. We also have internal reviews by clinical and coding specialists. We use an automated system to track. We supervise each case through senior managers. And we also engage relevant health practitioner societies and bodies, including the SA Medical Association and others, to assist us with the integrity and fairness of our processes. So this is a process that's been designed and evolved over many, many years. If I go back to my very opening remarks, Mr. Chair, we don't think it's a system that's perfect, and we will gladly welcome and take very seriously recommendations from your panel on how to make the system fairer to all participants. If I can move to slide 29, and I think we are touching here to some extent on the issues of Regs 5 and 6 and Section 59. I watched some of the testimony from yesterday and heard one of the witnesses for GEMS talk about high claims volumes. You have on this slide 29 some data from ourselves. We process roughly 275,000 claims a day. 94% of those are processed immediately, and the member or the practitioner receives the money in their bank within 4 to 5 days. This is a very important point to emphasize. This is highly valuable to doctors in particular and other health professionals. The cash flow is very important to them, and so being able to process these claims very quickly and get them their money, whether it's a member or a GP or a psychologist, is very important to them and to us. The witness yesterday, I think in response to a question from you, Advocate Hasim, you asked if an inaccurate code is put on, can your system pick it up? And she said no. They can't pick up systems that level of detail. Our answer is different to that. We immediately will pick that up. We have algorithms that would say this code is wrong for this discipline, and that would be rejected. So under regulations 5 and 6, our view, which I think is similar to what you've heard before, is that those regulations pertain to administrative elements of claims. Is all the accurate information on it? Is there a code? Actually, is the code correct? More or less correct? And we will immediately, and certainly within the 30 days, because this is done all automatically, we will either have paid that claim, or we will have queried it, and we will have resolved a coding-related issue that's not fraud, and I'll distinguish from fraud, well within the timetable required by Regulation 6. We see that as very different from Section 59.3. Our view, and this is based on sound legal advice, and we believe this to be settled, but we accept that there remains debate about this. Section 59.3 recognizes, the drafters of the Act recognize that there would be certain situations where it would necessarily take longer for certain patterns or frauds or other unwarranted claims to be identified. It is simply not possible to pick up certain patterns of fraudulent behavior claim by claim by claim, one at a time. So we need the retrospective analysis and so on. If we were to slow everything down to a point where we could analyze all the retrospective data within the 30 days, I think there'd be two significant consequences. The one is a vast increase in administrative expenditure, which would not be, we think, a waste, an effective use. But more importantly, I think this would have a terribly negative impact on, the 92% of practitioners who never ever have a claim queried, who never are investigated for fraud, waste, or abuse, and who get their money within 3 to 4 to 5 days every single time they submit a claim. So we believe the law is very clear and that we comply with it. When there are administrative issues linked to a claim, they must be paid or sorted out within the timetables of 5 and 6. Where there is evidence of potential payment of unwarranted claims, as envisaged in Section 59.3, we do not have to abide by those two timetables of 5 and 6. It's a different set of issues.
Let's accept that regulations 5 and 6 don't apply to fraud for the reasons you've set out. Who determines when an irregularity, I'm using that in a very broad sense, counts as fraud? Who determines when you are in the realm of fraud? And once that determination is made, what processes are there within Discovery to deal with that particular claim in a manner that is reasonable, fair, lawful?
Okay, thank you. Yes, so I think...
Given that 5 and 6 can give you no assistance, the regulations give you no assistance.
That's right. So I think that the first way, I'd begin answering you by saying that the default assumption in our entire operation of paying claims is of good faith on the part of the claims submitter, whether that's a member, a health practitioner, hospital, or pharmacy. So we assume that there is no untoward activity at all, and all we look for in nearly 300,000 claims, pouring in every day, is the administrative requirements under Section 5. Has everything been put in? And also, as I said, we have another overlay of claims intelligence that says an ICD-10 code for hysterectomy shouldn't come on a claim for a male patient. It happens. I'm giving you an extreme example, but it happens. Or I'll give you a more subtle one. This dentist is claiming for the extraction of a tooth number, which she claimed for 18 months ago. That'll be picked up immediately. Firstly, the claim will be denied. We'll try and sort that out within the 60 days, but that latter one, maybe both of them might be also referred for fraud investigation, but they'd be picked up and not paid. But every other claim, and if I'm not mistaken, I think something like 97% of all claims are then paid immediately. Some are referred because there's clinical complexity, we need more information, we need a form from a doctor and so on. But I think for purpose of answering you, Advocate Hassim, we can assume that the assumption is good faith and the claim is paid, and unless one of two things happen, we would never get to your question of now there's a question of fraud or waste. One of two things would have to happen. Some point after that claim was paid, a tip-off would have to arise that would lead us to go and investigate a practitioner or a hospital, or that practice would need to be flagged on our risk rating tool. And at that point, I think the set of processes that I'm about to go through are set in train. And all the policies and procedures, which I'll talk about, are in place to make sure that those processes are as objective, unbiased, and fair as the law requires, and as principles of justice and fairness require. Does that answer your question?
Please, it doesn't answer it from my
You will answer
perspective.
it when you get to the detail.
Can I
yes.
remind you, who makes the decision that fraud has taken place? That's the question.
Okay, so as I said, Advocate Williams, if I can answer in the two buckets. Tip-offs, every case that is tipped off to us will be investigated. And the investigation process, which I will get into, is a human process. We have people who look at the facts, look at the complaint, study the claim's history. They may decide at that point, and it'll usually be a team. No one investigator will decide on their own. They may decide there's no good evidence of fraud here. This is a pattern we've often seen. What this person is doing is a common billing error. Let's ask our field force to go and talk to them and ask them to please correct this billing type of error. We don't think there's prima facie evidence here of a deliberate fraud or some other abuse. Conversely, this looks like something serious. There's a tip-off that we've got that that the doctor gives false sick notes and submit claims. We need to investigate, and we will then put in motion, and I'll describe it, the way that investigation will happen. So the direct answer to you, I'm sorry I'm talking at length, is human investigators working under strict policies, procedures, and supervision.
It is these 55 experts and these 44
It's
investigators.
the 44. The 55 are really statistical and actuarial and analytic support, Mr. Chair. It's really the team of 44, some of them who are a subset of the 44 who are labeled investigators. Not all of the 44 are investigators, by the way.
They are the ones who decide if a doctor has committed fraud.
They would be the ones who decide that there's enough evidence here of fraud or abuse to take it further. As I will try and explain in a bit, the taking it further has different steps depending on what it has. They will then, in some processes call in that practitioner, always invite them to bring legal or other representation. And some of those will end with that first meeting where a valid explanation is given.
What are their qualifications? These 44 investigators.
They are qualified as forensic investigators, as far as I know, and my colleague, I'll ask for a minute to just talk to my colleague behind me. There is a formal qualification for forensic investigators, and as far as I know, all of our investigators are so qualified. Can I have 30 seconds? Thanks for your indulgence, Mr. Chair. So my colleague, who's the head of our forensics division, informs me that it's a multidisciplinary team. We have people with several different clinical expertise, doctors, nurses, dentists, and other health professionals in the team, coding experts. My colleague informs me he doesn't have the exact number, but the vast majority are also qualified as certified forensic examiners. I think that's a formal qualification.
How many doctors?
Actual doctors.
Yes.
One doctor in the team. This has also
So
been
this-
submitted to the panel, Mr. Chair.
I understand, but
Yeah.
one doctor is then in charge of these thousands of investigations.
I think it's one doctor. There are also other people with clinical expertise. I'm not sure one always needs to be literally a medical doctor. Also, if there are ever complex clinical cases, there are many other doctors in Discovery Health that the team can draw on. But I do want to emphasize a critical point here. It is an extremely rare case, if ever, that there's medical issues at debate around these fraud issues. These are not medical issues where you need clinical judgment. That takes us back to the questions you were raising much earlier about overutilization and abuse. These are cases of claiming for services not provided, filling in false sick notes, submitting a claim and providing the patient cash, selling a customer perfume and submitting a claim for medicine. You don't need medical judgments on this, and the vast, vast majority never require detailed clinical judgment.
I think the problem, Dr. Brumberg, is at that stage of investigation, because we now know that there is actually a lot of power concentrated on these 44 investigators, because they make the determination if there's been fraud or not, and they conduct the investigation. So they are the face of discovery to the doctors. The problem we've been having is doctors coming to complain that they are asked, and again, I don't want to be unfair to people with police qualifications, because that's vital in our society. But they are asked, frankly, by ex-policemen to produce facts that are clinical in nature at the stage of investigation. And they tell them that this information you require is unnecessary for the investigation you conduct. And the ex-policemen persist, and the doctors feel that is an unfair intrusion on their clinical training. I think that's really the context of the question.
Okay,
to
thank you.
open it up.
So if I can try and respond then, Mr. Chair. Firstly, just to correct one statement I gave you. On page 241 of the pack, this is one of our submissions, we've informed you that the majority of our investigators are certified fraud examiners with various healthcare qualifications, including 2 medical doctors, so I correct my previous statement, 3 pharmacists, as well as paramedics and other and nursing sisters, as well as 1 full-time legal counsel. We also work with experts from other divisions, such as the legal and clinical teams. I'm correcting that it's, I said 1 medical doctor. I'm now
So the
saying
correct
it's
answer is 2.
2. I also, in relation to the allegation about ex-policemen, of the 44 people who are full-time on our fraud division, 2 are ex-policemen. 2. And if I can now then come to the gist of your question, Mr. Chair, I want to make a couple of points. The first is that no individual investigator ever works alone on a case. They work in teams, they are supervised, they can never progress a matter, in other words, make a decision, even write a letter without consent and oversight from a supervisor. So, we do have a very carefully designed system to avoid rogue investigators or people prosecuting a case with their own bias or with untoward intent. And we do the very best of our ability to do that. To now come to your question about the information. There has been a lot of allegations about our requests for clinical information. We think the position on this is very clear. The first point to make, I think, is that actually the vast majority of confidential information, of truly personal information, is already in our hands because it comes with the claim. By law, as we were talking about earlier, the ICD-10 code contains that information, and the diagnosis is already known. So when we ask for additional clinical information, unless I'm mistaken, we're never asking for more than is already known. We also always offer the practitioner the opportunity to redact sensitive information. So I can imagine a psychologist.
I have to challenge you on that.
Sure,
I've read a lot, and I've never seen that offer in the correspondence. I'd really like you to refer me to correspondence where you've offered the practitioner opportunity to redact. And also on your other point, I've also seen numerous letters where the patient files and clinical notes are asked for, and that definitely is way more than the ICD-10
Yes.
code. So I think if you can just give us some, with reference to the documentation, to support your submission, that would be great.
We'll do that. We'll make a note to do that. But I was going to say, as you've made the point now, that for taking an example, say, of a psychologist, I can well imagine that beyond, let's say, a hypothetical diagnosis of depression, there would be personal details in clinical notes that are not relevant to the investigation and that the practitioner would not want to supply. But we don't need that information. The typical example for that type of investigation is we're seeing a practitioner submit claims where the average time of consultation way exceeds his or her peers. And we are wanting notes to see diaries and time stamps of the consultation, not what's going on in the family of the patient. It's irrelevant to us, which is why I am assured by my colleagues, do offer the right of redaction. I must also say,
I
Advocate
think that
Williams,
the problem with this point about reduction, we've had a lot of debate about this, and we've got this claim that people are offered. The reality of it, and this is also a chance for you to reflect on it. The reality of it is that your statement that you always do it is not borne out by the documentation that we have seen. Now, there's no point in trying to catch anyone out by saying you're not telling the truth, but I think the people internally who tell you that every time there is an opportunity to redact, that's not the case. That's as simple as that.
I can't disagree at this point.
Can I just, to slow us down, can I take you to 1615 of the bundle, page 1615, just to give you an example of what I am seeing in front of me.
1615. Okay, thank you. I have seen that, Advocate Williams. So we're there asking for 1615. So we're asking for 3 elements of information: copies of clinical notes, copies of your appointment diary, validation of time spent with members. Am I looking at the right document?
That's correct. So I'm sure you'll accept that that's way more than what you know from the ICD-10 codes
Yeah,
that
agreed.
are.
I do concede that completely.
And I'm also sure you'll accept that the clinical notes contain the most personal information that a doctor will encounter with a patient.
Yes, I do concede
You
that
can't
as well.
possibly imagine, in fact, more information which is more highly personal, includes HIV status, all sorts of
Yes.
circumstances which might surround particular illnesses. It's highly, highly confidential information.
I concede that completely, and I think it's also the case that it's very hard to imagine circumstances where we would need that particular level of detail. And so I would say to you, even if we don't formally in this letter say you may redact the clinical notes, if a practitioner responded to this request with the diary, with the validation, and with clinical notes, with all the information that they regarded as sensitive redacted, we would very, very comfortably accept that submission.
That's an ex post facto explanation. I've had this debate with witnesses about redaction, and that's where, as I understand it, it's the first time it's been mentioned. So that we see nowhere in the correspondence. There's no evidence that you've ever offered to accept clinical notes with redaction, as far as I can see.
Perhaps you can help us differently, Dr. Brumberg, by showing us the instances where Discovery has made an offer to redact information. Because, I think
if I can refer you to page 1955, Mr. Chair. There's a letter to a doctor.
You may proceed.
If you look at the first bullet point, yeah.
Thank you for that. And then my follow-up question, why is that not done consistently?
In my view, it should be done consistently. It should be done in every single letter. I would imagine that as of now, it is being done in every single letter.
But your testimony that it is always done, I mean, I take it that was given in good faith, but was it just based on what your forensic people told you?
Yes, it was. I think that, and it certainly was given in good faith. I think that you can now assume that all letters that go out as of now do make this statement explicit. I acknowledge there's no point in trying to not acknowledge that prior letters did not make the offer explicit.
Do the investigators visit the practices, or do they always require that the practitioners email the information? So in the previous example, and I see this one does ask for redaction, but the other on page 1615, there are about 20 to 30 patient files that are referred to. So I can imagine that that also would be quite difficult for a practitioner to comply with within the time period that's requested. Would, in such a circumstance, your investigator just visit the practice so that they could quickly scan, if the purpose is merely to see that they exist rather than the content?
Yeah. Advocate Asim, I think our general practice is not to visit, except, in relation to the undercover investigations, which we may come to later. We are very much guided, and I have to say this, and I'll say this more than once. Our approach in these processes is to be as cooperative and as accommodating as possible. When a provider comes back saying, please, can I have more time, we almost always will grant more than one extension. If they come back and say, I can give you this, but I can't give you that, we'd say, please give that. If they come back and say, these files are just too voluminous, I can't do it, we would find a way to accommodate that. So the vast majority of practitioners cooperate with us, find ways to protect what they regard as confident information, and the small number of cases where there's a breakdown, we find it is people typically trying to hide information from us. And if I can be frank, we believe they're using patient confidentiality as an excuse for not supplying information that will confirm the activities which we suspect are untoward. That's our view. It's a small minority. The vast majority of providers who we approach wholeheartedly cooperate, and we always will come to some accommodation on the information and on the requirements.
The problem, of course, is that we've seen instances where your investigators call a doctor, there's a doctor who came from Umtata, they call a doctor to a meeting, and at that meeting, they insist that they must sign an acknowledgement of debt.
Mr. Chair, I'm assured by my colleagues. I've never personally been present in a meeting, and so what I'm telling you now is in good faith, to the best of my knowledge. I'm assured by my colleagues that there's never a meeting where we use duress to force a practitioner to sign an acknowledgement of debt. We do record these meetings, we film them, we take careful notes. We always encourage practitioners to bring representation. Many do, some don't. But to the best of my knowledge, we deny that there's ever duress. I'm aware of complaints that have been submitted to you about that providers were forced to. And our evidence from our people who were present there is that those complainants voluntarily signed the acknowledgement of debt, never complained about them until this inquiry arose. And I think the timing of that is relevant as well.
Sorry, Doctor, I really don't want to labor it too much, but I just want to make one last point on what we were discussing about the notes in relation to the same practitioner at 1615. Where that practitioner said, I'm not in a position to scan, I'm willing to show you, in fact the words are, I've no objection in showing you my files, but not in a position to scan and send through to you, even if you were to pay for it. But was then consequences flowed, as we see from the next letter from Discovery, because he did not send it through in the end. What is to happen in those circumstances if a practitioner says, I'm willing to show it to you, but I'm not in a position to scan and send it through because I don't have the resources around me, or I'm operating in a part of the country where I don't have scanners and faxing and email or what?
So, I think, Advocate Hassim, again, I'm not, it's not my daily work to have been involved in these, but, what I believe would have happened, and I'll ask my colleagues to correct me if I say something inaccurate now, is that the general stance would be to find any way possible to get the minimum information that our team would require to either conclusively exclude or conclude that there has been fraud or other kinds of abuse. And so if that practitioner was just making some kind of offer, look, I can send you this, or would something else help, or could you send somebody to come and look? My belief is we would always try and accommodate that. We're not here trying to trap people or pin them down because they're unable to for logistical reasons. As I said, there is an element of human judgment, and I think our investigators generally are very experienced and are also able to detect that in certain cases these are delaying or prevarication tactics, or the practitioner is trying to hide their guilt by making these arguments. Can you indulge me a sec to just
Why
ask
do they
if I've
assume
left
that a doctor is dishonest by prevaricating and trying to hide information? Because my expectation of a skilled forensic is that they assume the doctor to be innocent.
They
as
do
opposed to the
assume,
opposite.
yeah, I think they do assume all to be innocent at the beginning. As I said, Mr. Chair, the vast majority of practitioners we write to very quickly provide the information we require. And if they can't, they provide a good explanation for why they can't, and that gets accepted. So we are here talking about a small minority of cases where there is some reason why they may not supply. And what I tried to say, perhaps not articulately enough, is in a subset of those, an experienced practitioner may suspect that this experienced investigator may suspect that this practitioner is trying to hide something. They're innocent until proved guilty. We of course accept that. I was just speculating that that may be in their mind. If you can just allow me half a minute to talk to my colleagues. So my colleagues are pointing to an example of the accommodation I was mentioning to Advocate Hassim at page 1268, paragraph 17, where the practitioner indicated in an email that an extension was required as the Wi-Fi at the practice was out of order, and Discovery Health telephonically consented to the request. I believe that does represent general practice, that our teams would never unreasonably refuse to accommodate either requests for extensions or other ways to supply information or requests to redact information.
Dr. Brumberg, let's proceed. I mean, where we were in the general debate was your justification for clawing back after the lapse of the 60 days.
That's correct.
Under Regulation 6.
That's correct. So I am at slide 30, Mr. Chair. Thanks for getting us back on track. I was making the point, and we have touched on this in the earlier part of my evidence, that we pay these very high volumes of claims immediately in good faith using automatic rules systems. We've talked about the direct payment arrangements, and Advocate Hassim, here are the numbers in response to your earlier question. 87% of GP visits and 91% of specialist visits are on such an arrangement. This comes with risks and rewards. The risk in a direct payment arrangement is that members tend not to see the claim ever. So what happens is the claim comes directly to us from these practitioners. We pay it directly, and you don't have the opportunity for a member to cast their eye and to say, hold on, this doctor submitted a claim for 2 visits, but actually I only went once. So this direct payment arrangement has the huge benefit of immediate settlement, the fee cap that you named it as, Advocate Williams, which protects the members from additional payments, but it creates this additional risk of the loss of another pair of eyeballs on the claims. And that is one of the reasons why the retrospective analysis under 59.3 becomes so important.
Can I just ask a factual question about this? So are you saying that the member receives no notification whatsoever that the doctor has submitted a claim and that it's been approved or not approved by you?
No. The members actually receive quite a lot of information. They get something we call a daily claims notification, which has certain information on it by SMS or email. We also send a monthly, more detailed statement. But I can tell you, and I think that probably makes common sense to you, that a statement like that, which is simply informing you that we've received these claims and they've been paid, is there for the curious and the diligent, but it has a very different impact on people from getting an account from the doctor that says, please pay this and submit it to your medical aid, which is what would happen absent a direct payment arrangement. I think any one of us would apply different quality of mind to that account than to what you may see as spam coming from Discovery Health, which is coming a few times a week if you're claiming, updating you on what we've received and what we've paid. It just is, I think there's a different application of mind from your average member who'll say, hold on, I've got to write a check now, I've got to do an EFT, but this didn't happen. And we do find that's where some tip-offs from members come when they look at at their invoice that they have to pay.
Yeah, that's my concern, which suggests the members are looking at it. I suppose you're saying looking at invoices which the members themselves have to pay.
I think they look at it differently.
I mean, we're in the realm of behavioral economics here. I mean, I struggle to accept it as evidence, but I see the argument.
Yeah, I suppose I'm not. I'm simply making the point that this is one of the reasons we have lost, if you like, some measure of protection that comes from the situation where members receive an account and pay. Only some measure, and you can decide how material that is.
And I suppose if it's depleting a member's savings account, they'll be more likely to apply their mind.
Exactly. Or they have to literally pay an EFT and then claim back if it's a large amount for a hospital visit. I'm moving to slide 31, Mr. Chair. This takes us back to the identification of these potential cases. I'll go very quickly because we've covered some of this. We just make the point here that there are these 2 sources. On average, over the last several years, 53% of tip-offs have come, of cases have arisen as a result of tip-offs. That, as I made the point earlier, has increased now to a higher proportion in recent years. And the balance comes from statistical analysis. I'm going to keep moving, and please, if you need to interrupt on any of the prior points, please do so. On slide 32, more detail on the statistical analysis. We use these proprietary risk rating tools.
Before you move on, can I
Yeah.
just ask you something about one of your affidavits? If you can turn to page 557. So while you're looking for the page, to give you some context, if you allow me to give some context, it's a response to Gacheni's evidence, who gave oral evidence at the hearing. It's an affidavit signed by Marius Smit, who's your head of group forensics. And it responds to many of the allegations, but those aren't what I'm trying to focus on. I'm trying to understand a statement that's made at paragraph 17, which says, during August 2017, Discovery Health initiated a review of the hours per day claims submitted by all social workers. This review was conducted using the data analytics system referred to in paragraph 13 above. That suggests there's some other kind of review that was done. which is different to what you've been describing, this whistleblowing scenario versus the Raptor, RT and Raptor way of initiating complaints. What is this, and when do you do these sorts of reviews? It seems to be a third way that, it certainly looks like a third way that suspicious claims might come to your attention.
I think that's correct, Advocate Williams. It's an ad hoc situation. So the regular channels are the two that I just described. From time to time, there will somewhere in our system, either because there have been several tip-offs or because several types of one practice, say in this instance social work, have been flagged, or for some other reason that's emerged from certain analysis, the senior team in the forensics unit will say, we should proactively study certain patterns among social workers in this instance.
So can you tell us some more about these ad hoc processes? Or point us where in the papers you've explained this before.
I'm not sure. I'm going to turn, if I may, to my colleagues. I'm not sure we have explained them before, but what I'm just explaining to you now is there are from time to time these ad hoc investigations when there's some evidence that there may be a general pattern that we should look at. Can I turn for a second to chat to my colleagues?
Dr. Brumberg, we are mindful of the fact that this has been going on for 2 hours and 20 minutes. So maybe it's time to take a short break and then we proceed from there. That will also give you time to fully consult with your team. And whilst you are on that, I do have a question. When you say sometimes we study certain patterns of particular disciplines and we zoom into those patterns, I want specific examples of where you have studied these patterns and in which disciplines. And you can pick in the past 3 years or in the past 2 years where this has actually happened. Thank you. We will adjourn for 10 minutes. Thank you, Dr. Brumberg. We may resume. You may start by answering the last question before the adjournment.
Thanks, Mr. Chair. Thank you for the break. Much appreciated. I must point out to the panel that the response I'd given to Advocate Williams about that specific investigation actually was not an accurate explanation of our process. I do sincerely apologize. My colleagues have explained to me that this review is one example, I'll give you others, of actually a routine phase in the application of the risk rating tool statistical analysis. And I think I can best explain it as follows. We run these tools against literally the entire database of practitioners and all claims on a monthly basis. When the results of those come out, we identify certain patterns. For example, that in this particular instance, there seem to be flags arising quite commonly in social work practices. That would then lead to a second phase analysis as part of this RRT, in which all social work practices would be analyzed, for example, on the number of hours billed per day. And that may then yield a number of practices that need to be investigated or none. So because there are 80 different disciplines, and because each month a number of flags across many different disciplines will be raised, our team doesn't have the capacity every month to do a systematic, deep analysis on all 80 disciplines. So there will be some decisions about saying, you know, this month we're going to prioritize 3 or 4 disciplines for the second phase. And that would be driven by the number of flags that have arisen out of the monthly analysis of the entire database. So, Mr. Chair, you asked for some other examples of things that would arise. I can give you some. For example, there may be a similar to the social work investigation that was referred on page 557. Similar one has been done on psychologists, looking at for all psychologists submitting claims, what are the patterns in average billing hours per day? Are there any outliers, etc.? You asked for.
When was the one on psychologists done? Could you give us dates?
That's a hypothetical. I'm giving you, unfortunately, Advocate Williams, I'm giving you hypothetical ones. If you want a list of which ones were run when, we would probably have to go back and reconstruct that.
Yes, I mean, that's what we were looking at. Is if, say, like in 2018, Discovery decided that social work was an area of risk and it focused on it.
Okay. So as I sit here today, I'm not able to provide you that level of detail myself, but I think we will go back and provide you with as much as we can.
Well, your forensic team is behind you.
Yeah.
And they are not giving evidence for
No.
reasons that you've decided. But they have the information. They can tell us when did they prioritize social work, when did they prioritize psychology.
Mr. Chair, I think I would request that we be allowed to submit this in writing. I don't believe, even though my team is sitting behind me, there are large numbers of these investigations going on at any one time. I don't think they could reliably give you a list of exactly which disciplines were investigated last year or the year before, but we can do that for you in writing if that's acceptable to you.
Thank you.
Okay. I need to correct Advocate Williams. I wrongly stated these are ad hoc. They're not ad hoc. I think another important criteria that is brought to bear in deciding which disciplines is, I said firstly, the number of flags arising monthly. A second is that the senior leadership of the forensic division is monitoring from time to time, are we getting out of balance in investigating 1 or 2 or 3 disciplines? And so they're trying to also ensure balance. So I would also say, look, social work has been a focus for 3, 4, 5 months or whatever. Now we should actually make sure we're applying due diligence to others as well. So that would be another criteria.
Is there anywhere in the submissions or the bundles where this is explained?
I can just ask my colleagues for a second, please. I'm told that all of this detail was explained to Dr. Kimmy in our office. We took him actually through the spreadsheets that showed these processes.
Okay, well, we have recordings of those meetings, so we'll give it a listen.
I think that the real point that is of inquiry is whether this part of studying patterns per discipline, because it is certainly a new part of your testimony. And that's really the point, but I think your point is that you will supply us with details in due course. So where are you now on your slide?
I'm on slide 31, moving to 32. I think, Mr. Chair, if I can just emphasize again, I think I understood you to be saying this is a new part of my evidence, which is correct, but I do want to emphasize that this process is not new. It is actually, it was my mistake, it's a routine part of the application of our statistical analysis. We did explain it to Dr. Kimmy. So if I can take you to slide 32, please.
Sorry, Dr. Brumberg, would it be correct to say that the investigations therefore come through three streams? One is the tip-offs, one is the analytics, the risk rating, the Raptor system, or the
Not
flags that are outlined, that are the outliers that are flagged, and then through routine deep analysis, which may pick out certain risk areas that are then opened up for investigation.
So I think just to maybe slightly rephrase it, and then I also just do want to check one thing with my colleagues. So correct, one source is tip-offs. Not the Raptor system you refer to is actually the case management, so that's an aside, the risk rating tool. I think that the right answer to your question is that it's still one source, but there are two phases in that source, in that second source, the statistical analysis. Phase one is you run it against all the data and identify flags. Phase two is you do certain detailed analyses on certain disciplines, and both of those phases would yield potential cases for investigation. Is that correct? If I can just clarify them. So I think I'm correct, but actually what my colleagues are explaining is that because we run in phase one, we run the data across every provider in all 80 disciplines, all the claims. So you get a high risk score. The highest risk scores in January, you can't compare a social worker to a surgeon to a psychologist. So they don't ever take a red flag from that first phase and investigate it. They would then go down into the disciplines, and only flags emerging within a discipline that's been investigated following the phase one would be identified for further investigation. So it's actually two sources, tip-offs and the risk rating tool. And the risk rating tool has two stages, and stage two yields cases for investigation. Stage one gives an indication of which disciplines need to be more detailed, investigated in more detail.
Was this information given to Harris, Snoop, and Mulabatsi?
Yeah.
Can you point me to where in the submission it was recorded? Or sorry, in the opinion that they gave, it was recorded as an instruction?
With your permission, my team will look for that while we're carrying on. Can I carry on, Mr. Chair?
Yes, you may.
Okay.
You are still at page 32.
32,
Yes.
and I'm getting a bit into the statistical analysis. We have covered a fair bit of it here, but just to make the point that these tools comprise 30 independent risk metrics. We're now starting to touch on the allegations of race bias, and it's important at this point to note that none of those metrics have got any links that we can tell to the demographics of the practitioner. And we've studied that ourselves. I believe Dr. Kimi has asked himself that question as well, as have our other external investigators. So these are not, some source of implicit race bias in these, in the risk factors. So if you look at the last bullet point on the slide, I think it explains the way I've tried to now answer your question, Advocate Williams, that in the first round, we get a single risk score, and then we compare, practitioners to their peers before we decide that there's genuinely a reason to investigate.
In your earlier testimony, sorry to interrupt, you indicated there was a cutoff, is that right?
I think there is a cutoff that, so in phase one, there'd be a cutoff for scores that are above a certain score that suggest the need to go into a discipline-based investigation. So I do think, given that you're getting every provider across 80 disciplines is going to get a score, there will be a number which leads to the second phase. Do you want me to ask what that number is? Is that relevant or?
That's sufficient for the moment.
Okay, thanks. Slide 33 is just an example of the application of this tool where we have 3 practitioners on the left in allied health professions and 3 dentists on the right. And what you can see here is, sorry, I should bring the slide up. You can see with color coding that if you take the provider, let's say in dark blue on the left or in dark blue on the right, they have high scores on certain of those metrics, and then there'd be a total score that would be added up, and that dentist in the dark blue, provider C, would come up with the total score. This is just an example of how this works. I'm now on slide 34. At the bottom of slide 34, this repeats a point I was making to Advocate Hassim earlier, that these cases that are identified are prioritized according to prioritization factors. There is an application of human judgment here, so just to acknowledge that point to you, again, Advocate Williams. Moving to 35. Once prioritized, the case management system automatically allocates to individual investigators. The criteria might be the type of case and the existing workload of that investigator. And as I've said before, we supervise every case. No investigator makes decisions or takes actions alone. And we track all of these actions for audit purposes in this RAPTOR case management system. Moving to slide.
Can I just ask a question about that Raptor case management system?
Yeah.
Once the information is in there, do you see the surnames of the practitioners?
Yes, apparently the answer is yes once it's registered.
I mean, the one thing you don't seem to deal with in these slides is what happens when you have decided that there is a risk in a general practice. So if you say there's a risk in social work, it's unclear what happens to that decision, because the way this is presented, it is as if the risk is always individual based as opposed to a practice itself. So if you did your point now, as I understand, is all of this emanates from the risk assessment tool. It then produces a risk per individual or a risk per practice. So if you then look at the second possibility, which is the risk per practice, so we've decided social work is a problem, what actually happens?
So as I understand it, and my colleagues will correct me if I get this wrong again, but I think it's clear now. What would then happen is we would do an analysis across the same metrics across all social workers for a defined period of time. And we would identify through that analysis both high scores using this risk rating tool, but also certain patterns would be investigated. So let me give you a very concrete example here. If you found, I'm just trying to find for example, we could say that there was on dentistry, there may be that we're finding a pattern of very high proportion of visits have got x-rays being done on them. The study, so that would come up in the first analysis. You'd see a few flags. When you look at those flags, you see this is a pattern. The team would then do a detailed analysis across dentistry, but they'd be asking themselves certain questions about dentists that arise from the initial analysis. So in this case, how often does the average dentist do an x-ray on the average patient? The social work example would be a similar one. What is the average number of hours per day that a social worker bills? So when you ask that specific question, you can get a comparison between every practice on a very specific data point, which is the number of x-rays done by the dentist or the number of hours billed by a social worker per day. And that allows you, comparing only within one discipline, to identify outliers. And if we then found outliers on that particular question, we would investigate those outliers individually. So it's, if you like, two levels of aggregate analysis that then flag individual practices for investigation.
And what happens to the allocation of resources? Because the risk rating tool is an ongoing tool that is applied daily. But once you decide social work is a risk area, it seems that you would then have to reallocate your resources to focus on the risk area. Does it mean that you devote more resources on social work or on psychology?
I think that the right answer, Mr. Chair, to that would be depend on which disciplines are being prioritized at any one point in time. So that would depend on, has there been a number of cases that have led to, let's say, this one you refer to in the bundle about social work hours, then resources would be allocated there. If at another time they might be allocated to a different set of disciplines. Just to remind you, there are 80 disciplines and a limited number of investigators, and one of the criteria is ensuring that forensics don't spend every year, every month, every week only on one or two disciplines, that the resources are spread to looking for patterns in different parts of the billing practices.
And how frequent does this prioritization of areas take place? Is this something that's done monthly, or is it 6 months or a year?
As far as I know, it is done monthly after the monthly report, but if you can indulge me, if I can just confirm. Mr. Chair, the information my team share with me is that this is, if you like, an ongoing process as opposed to static monthly. So when cases are flagged out of a monthly report, if there's capacity to investigate certain cases, then those cases would be allocated into the RAPTOR system, and where necessary, more detailed discipline-related investigations would be done. So it's not a monthly standard process, but this was really explained in detail. I can refer you to the H&M report and to Dr. Kimi, where I think we've explained it in very detailed and concrete terms.
Please do.
Can you guys give me the H&M report? I think it's at point 6.6.3. And also on page 69,
Yes.
at 7.6.
Thank you. And where is the decision taken? So you've now decided that social work is a risk. Someone needs to decide that resources must be devoted to it. So where is that decision located?
I think that is located in the prioritization that comes out of the analysis, and then whether there are resources available, or it may be that in a particular month, a number of high-risk cases and their disciplines are flagged, but the RAPTOR system is full and there's literally no capacity, in which case no new resources would be allocated until further resources became available. And I believe the decision then flows from that. So when capacity becomes available, the most high value or highest risk cases would be prioritized. As I told Advocate Hasim, that would be the third criterion, and then resources would be deployed based on that allocation.
who makes that decision that we are going to focus on social work because we've identified it in the risk assessment matrix as a high-risk area?
If I can just confer for a second. Mr. Chair, can I ask your permission to ask Maria Smith to take the chair for some time and answer these questions? I think it's going to be more efficient and you'll hear it from the horse's mouth.
Thank you. Do you want to do that
I
now?
apologize. I've been wasting your time. I do apologize.
No, that's fine. Maybe he should come forward and take the oath then. Thank you, Mr. Smith. Do you want to take the oath or the affirmation?
I'll take the oath, thanks to you.
Thank you. Would you say after me, I and your name,
I, Marius Meyer Smith,
hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If so, raise your right hand and say, so help me God.
So help me God.
Thank you. Where do you want to start then?
Chair,
Maybe you can start by explaining to us and those listening who you are and why are you qualified to sit there.
Sure, Chair. I'm head of the Discovery Group Forensic Services. I've been employed in that role for the last 20 years. I'm a certified fraud examiner, but by qualification, I'm actually a pharmacist. But I hold various, forensic or investigative qualifications. My main expertise is obviously within the healthcare environment. I've been doing healthcare investigations and managing a healthcare investigation team for the last 20 years. So is that sufficient?
Thank you. Well, that's more than enough. Could you perhaps start with the last question just to get you settled? I mean, what the point really is, once your risk assessment tool has identified a discipline as a risk area, who decides that that discipline should now be pursued for in-depth forensic investigation?
Sure, Chair. I need to explain the entire process to give context to the answer, because there seems to be some misunderstanding, and I just want to re-emphasize that we spent I think close to 3 hours with Dr. Kimi, where I actually took him through what the risk matrix looked like and what it looks like at a per discipline level and how we register the cases. So we have explained that process, but I do understand that there's some confusion from the panel, and hopefully I can address that. So the risk rating tool, and please just bear with me if I repeat things that we had in our submissions, but I think it's important to understand the context. So the risk rating tool runs across all disciplines on a rolling 3 years worth of claims data. So on a monthly basis, we refresh the data. So you'll add the new month's data on this side, and you'll drop off the last month's data from the previous 3 years on that side. We then generate what we call a risk matrix. Now the risk matrix then looks at all disciplines and all the claims across all the criteria or the factors that we've provided to the panel. And it assigns a score per factor and an aggregated score per practice to all the practices. So when you open that spreadsheet, it is quite an enormous spreadsheet. You'll see, I think there's something like 38,000 practice numbers, and then the various scores for the various factors that applies to that particular practice type. I think it's important to understand that not all 30 factors that we use apply to all disciplines. So some disciplines the factor doesn't apply and it won't score there. So it is not possible to simply just look at a score and try and compare practices from various disciplines against each other. So, I'm going to just use an hypothetical example. A score of 30 in a GP practice cannot be compared with a score of 30 in a dentist practice because they score on different factors. So you cannot do that. So in order to identify where the problem areas lie, that risk matrix gets then divided into disciplines. However, the important part for the purposes of this inquiry is, at that point in time, we still only work with practice numbers. So now at least we can compare apples with apples. So if you go into the discipline of social workers, it will show you all the social worker practice numbers that has claimed for us over that 3-year period, plus the scores that they have. It then gets sorted from high to low level. So you can obviously see which is the practices that scored the highest across the various metrics that's applicable to that particular discipline in that spreadsheet. So that's the one part of the step. The other part of the process is then our Raptor system, where these cases lie. Now, the Raptor system is a case management system. We use it to register cases and allocate work to investigators and to track everything that the investigators do. The capacity on that system is limited. We cannot load 10,000 investigations on it, and it doesn't make sense to load 10,000 investigations on it if you can only deal with 100 or 200 cases on a monthly basis. So we work roughly with a number of about 3,000 to 3,500 cases that we want to register on the Raptor system that lies in the pipeline and then gets allocated to investigators as their capacity becomes available. So if we see the number drops, and it's not an absolute number. It's not 3,000. It's roughly in that region. 3,500 is we feel comfortable with being able to manage on the Raptor system. So let's say it drops below 3,000. We will then take the risk matrix that gets generated on a monthly basis. We will look through the various disciplines, and we will register the highest scores onto the Raptor system. They will fall in line, and then the normal prioritization categories gets applied to them, and they get allocated to a particular investigator.
So do you register these cases? Do you take them from the output from the RRT tool to the Raptor system? Do you do that personally?
So it's done by my let's call it second in charge, the divisional manager. So it's individual that reports directly to me. It is at manager level. It's not an investigator that does that. So the person that does it is not part of. Is not actually doing investigations. It's fulfilling that function. It's one of my operational managers, if I can put it that way.
What does he or she see?
So all she sees, it's a she, actually in this particular case, all she sees is the discipline, the practice number, and the score, and also obviously where that score comes from, because the score, the aggregate score is made up of a score across various factors. So it's a score, discipline, and a practice number. That's all that the individual sees. So we register the case on a practice number, it goes into the system, it lies in line then and gets allocated to an investigator when capacity becomes available. So it's not technically correct to say that we focus on a particular discipline and then we only investigate that discipline for a particular point in time. I think the point we're trying to make is that it's not possible to on a continuous basis investigate all disciplines equally. So when we register cases, we go through where the scores lie, and in that particular month, referring to that the affidavit, we registered cases from the social worker discipline. Doesn't mean that we're now going to focus on social workers and we left everything that was lying in the pipeline. The case will get registered, it will sit there, and it will get prioritized and allocated to an investigator. Also, something that might not be clear at this point in time is that not all investigators investigate all the disciplines equally, because I mean there is complexity to certain of these disciplines. So I do have an investigator or a group of investigators that specializes in dentistry. So when there's a dentist case, it will get allocated. So while we're investigating social workers, for instance, there will be many other investigations across a whole lot of other disciplines that's allocated to other investigators. But what we're trying to do at the end of the year is that we then look at all the cases that we did investigate and try and determine that at least we cover all the disciplines, that we're not missing a particular discipline that might have a particular concern that we never investigate. Or also the other side, not create the impression that we're only investigating some disciplines and not others, or we're only focusing on a particular discipline. You must also understand that the number of flags that you might get in a particular discipline is also going to be different. So sometimes you might find a discipline that for whatever reason have a lot more high-risk practices that gets flagged than in another discipline of equal size. So if I can take a hypothetical example, you might take social workers and physiotherapists, and you look at the disciplines, and there might be 10 high scores in your social worker group, but only 5 high scores in the physiotherapist. But what we're trying to do is to at least make sure that over a 12-month period, we actually give attention to the various disciplines that claim from us.
All right. So from your perspective, the statement made earlier that sometimes you study certain patterns in certain disciplines and you give priority to those is untrue.
I won't say it's untrue. So if you're looking at social workers, we know through experience that what you'll find in social workers is abuse of time code. So so the pattern might be claiming more hours than what is in a particular. But that's why a particular metric will apply to that. To that discipline.
So it is true that when you identify a pattern, you do give that discipline priority.
If we identify by a pattern, we will give the practices within that discipline that scored high priority. We won't give the discipline priority. So, it's still this manual process of registering cases on the Raptor system by going through discipline by discipline. So it might be that this month we only have place to register an additional 50 cases onto the Raptor system. And we might get that 50 cases from one discipline that's got a whole lot of high-risk scores in that discipline.
That's why I was asking, what are the practical examples where you've identified patterns per discipline because the score is high? I mean, I accept that what happens at the beginning, everything is factored into a blind or neutral system. It then produces outcomes that no one can predict. But those outcomes will then tell you which direction to follow. So we were debating social work, and I think clinical psychology was the other, and whether or not social work ever received a high rating, so that from your perspective, it deserved a focus. So that's why I asked, give us the examples in the past 3 years where this has happened.
It's going to be very difficult to give you the specific and say at this point in time, this is the pattern. What we can give you and what we have available is the type of patterns that we've identified across various disciplines over an extended period of time. We've never had
Mr. Smith, let's help each other. I mean, you came here because your CEO couldn't answer the technical questions because he's not close to the detail. You are the person who should now give us the detail. You surely know where you have given priority to particular disciplines, and even if it was last year or the year before. So please help us, give us the information.
What we can do is if we go and look at the results and make deductions whether we gave particular priority to a discipline. So if we look at 2018, we can tell you in 2018 we've done 10% of our investigations was in this discipline, 5%. That information we have available, and we can then link to that. We can link, what is the main issue that we've identified, because we actually do that on an annual basis, specifically for the reasons what I said. It's my responsibility to ensure that at least we're investigating the entire spectrum of fraud, waste, and abuse that might occur out there, and that we not get caught up in a trap where we're investigating only specific types of fraud, waste, and abuse that's only that's linked to only specific disciplines. So that
don't
information
think,
we have available.
Yes, no, I don't think that the suggestion is that you have investigated discipline X and ignored discipline Y. The question is you've given priority because it is a high risk. If you look at your own presentation at page 32, this, the third bullet point, this is what the CEO said, which led to this question. The practitioner risk rating tool then applies algorithms to identify high-risk practices. It does not prove FWA, but flags high-risk practices or patterns. And that's where he then made this example about social work. And that's why I said, well, give us the examples where this has been flagged and the decision has then been taken that we should prioritize it because it is a high-risk area. Not to say that you've ignored other areas. So I want to know, where have you identified these patterns and what has been your investigative response to them? Since the question seems to me to be simple.
Sure. Can I just, to just clarify, if we then can agree on the definition of what we will regard as a high-risk discipline, so my suggestion would be that if we've identified more individual practices in one particular discipline that scored high than in another discipline, we would regard that as a high-risk discipline.
Yes. No, I'm happy with your definition because you work with the detail.
Yes.
I just want to know, in 2018, social work was the problem, we devoted resources to it. In 2017, clinical psychology was a problem, we devoted resources.
I understand. Can we provide that detail to the panels for which years do you want? I don't have it at the top of my head. I know that social workers, I know that psychologists, I know that physiotherapists in the recent past.
Let's take the ones you know. Yeah. So it's social work.
Social workers, I think psychologists is here. Have you got? Yes, I've got the data here.
All right. Thank you.
Yes.
These include tip-offs. Let me just take a look at tip-offs.
Then, Chair, I just, we can follow up on this. We have, I understand, given this particular data to Dr. Kimi as well, but we're just opening the spreadsheet and I'll take you quickly through the high-risk disciplines.
While you're doing that, can you, so I understand the high-risk individual practices, then you pick up a pattern as a result of that, then you look at that discipline in which you see the pattern, and then when you look in that discipline, applying particular factors that are relevant to that specific discipline, you then pick up flags based around certain data points, and then that will identify individual practices within that discipline. And what do you then do once those individual flags come up as a result of your pattern analysis? What's the next step after that?
The next step after that is that the cases will get registered on our Raptor system.
And how long does it take between the time it's registered in the Raptor system and it is then investigated?
Depending on the priority that would be assigned to that particular case. So you might have, so there's a high risk score in that particular discipline, but if you look at maybe the rand value exposure to that fraud, it might be very low. So there might be a whole lot of other cases in front of that will be investigated first, just because of the quantum is higher.
So it doesn't follow a queue. It doesn't necessarily follow a queue.
No, the queue is not 1 to 10.
Yeah.
The queue it falls into a queue, but it gets prioritized in that queue.
It will be weighted.
Yes, weighted, and then our explanation is that if you can explain it, if we start off with one pool, in that pool you will have all the cases that's generated through the risk rating tool, as well as the cases through tip-offs. So tip-offs will have the first priority, and thereafter we'll start looking at the other cases based on on the quantum, and then obviously also the availability of resources to investigate that case. So we don't, I mean, it's senseless to give to an investigator 200 cases in their inbox that they must give attention to. They simply can't. So what we do is we set what we call handicaps per investigator, depending on the experience, the type of cases that they investigate, etc. So let's say your handicap is 30, you will never have more than 30 cases in your investigation pool that you're busy with on an ongoing basis. As you close cases, another case will be allocated to that particular investigator based on the priority of that case in the broader scheme. So it's, I mean, it would be, I think it would be irresponsible for us to have a number 1 to 3,000 queue, and the case that sits in number 3,000 is a high-risk case that's costing
and
us.
it's waiting queue. Sure, I got that point. So then it gets allocated to the investigator. Once at this point in time, it's still only practice numbers.
Once it gets allocated to the investigator, the practice name will be there. So from on the identification side and the registration side, there's no practice name. But once the investigator gets the case, there will be a name attached to that. So the investigator will know this is the name of the practice that I'm investigating.
So do you know the name of the practice, do you know the name of the practitioner when you give it to the investigator?
I don't know the name of the practitioner when we register it on the system. Once it's on the system, the name of the practitioner will be known. Because then
So
it
your
only
answer
goes
is
to
yes.
no. So it depends on when it is. I
No,
think
I
it's
understand.
important.
I understand you don't know the name of the practitioner when it's when it's an output of the RRT system. When you give it to the investigator, you know the name of the
Absolutely,
practitioner.
yes.
Thank you.
Just to finish up the line I was pursuing around the discipline issue, you've mentioned social work and psychologists. Is there any other that comes to mind?
Chair, if I could intervene, can I please request that we provide this in writing? We'll do this.
All right,
We're
I
just
will-
nervous to do this on the fly. We will answer your question fully. We would just prefer to have the time to do that. We'll do it as quickly as possible.
No, thank you. I think we should probably close this part of the question on that part.
Very much.
Could I also, just to take that again, remember that we dealt with the high-scoring disciplines and high-scoring individual practices and what you do with them in terms of the priority. This is dealt with in Dr. Broomberg's slides at page 34. We know what happens to them. The high-scoring cases on your version have got the potential, higher potential for FWA, so they become the priority. In the last bullet point, these are then prioritized on the RAPTA system, right? You say it's using objective criteria without reference to race or any identity factor of the practitioner. But presumably then someone takes these high-scoring cases and puts them at the top of the list, even if it's not at the top, but closer to the top, so they can be given priority.
As I explained, the prioritization happens in the system based on the criteria that we've set out. So it's not a manual prioritization that takes place. The system prioritizes it and allocates it according to where there's resources available to investigate that.
Yes. And then once prioritization has happened, because this is now registered, just explain exactly at what point do you know the name of the practitioner?
If I go into the system, I'll be able to see the name of the practitioner.
Yes.
That, for all cases that's been registered on our system and prioritized. So the name would be on the RAPTA system. There we can see the name.
So the system is blind only until the practice is on the, what you call the
RAPTA system.
well, the RAPTA case management system.
Yes.
Yes. But from there onwards, everybody knows the name.
Yes.
Now, would you also accept that knowing the name, I mean, this is, I don't think it's controversial because your own experts accept that knowing the name predominantly, 95% of the time, means knowing the race of the person.
I agree.
Now, yes. So at that point, once you know the name, Discovery knows the race of the practitioners that are the subject of investigation. Now, just tell me, I mean, I know we have extensive evidence given here by experts disputing what Dr. Kimi says, etc. But from your own personal experience, is the majority of doctors that are investigated by Discovery white or black?
So, Chair, obviously we've done the analysis, but I want to answer it in two ways. When the allegations was made, obviously the question was posed. You know, what is it? And my intuitive answer was that I think it's about equal. You know, that because I see equal number of white people coming into the office than black people coming into office, not having done any analysis previously. The second part of that question would have been then, is there any, is it disproportionate? And my gut feeling was that it's not disproportionate because honestly my view was that the sample group, if we're talking about the 38,000 practices that claim from us, my personal view at that point in time, before we did any analysis, was that the split there is probably 50-50. If anybody asked me, what do you think it is, I would say, well, I think 50% of our practitioners is black and that claims from us, and probably 50% is. But obviously your question is absolutely right. Once we investigate, once we see the name, once we see the individual, we know what the. But at no point in time did we ever feel uncomfortable that there's a disproportionality in what we're finding based on the belief that the split in the population would roundabout be 50-50.
No, I accept that. What I'm trying to really get to is now that you know the facts around the 35,000 and you know the split there, and you are the person at the coalface of the investigation. What is your honest answer to this panel about the disproportionality? Are you saying that there is a disproportional impact on black doctors, or are you saying there is no such disproportional impact?
Chair, we're dealing with that later in our presentation, and the stats show that there is a disproportionate
but you are the right
impact.
person to answer us, you see, because you are the head of forensics, so that's why
Absolutely.
I'm putting this question to you.
There is based on the statistics that we now have, it is clear that there is a disproportionate impact on black practitioners as opposed to white practitioners.
Chair, could I come in, please? I think, as my colleague said, we would like the opportunity to take you through our full analysis of Dr. Kimi's report, because the fact that we've identified, and we agree with Dr. Kimi, that when you look at the number of cases initiated, it is disproportionate in relation to the racial proportions of billing practices, by no means leads to a conclusion that there's racial bias in the process. And there are two critical elements that we want to show you there. The first is that actually, when you look at the outcomes of the investigation process itself, how many cases turn out to be valid? What percentage of cases turn out to be valid? The numbers are exactly the same between black and white practitioners. Secondly, in what proportion are recoveries made? Exactly the same. And we believe that is very strong evidence that even though from the minute the investigation begins, when names are known, to the conclusion of the investigation, there is no evidence of race bias or even racial differentiation in the process and the outcomes. And so the entire question becomes, is there the disproportion then seems to arise, there can be no other place, only from the initiation of the investigations. And that is the area we must now interrogate.
So can I ask a question on this point? Because this is what we've been asking Mr. Smith about the facts around initiation. And if I can just go back to Mr. Smith. So I understand that you're going to provide us with the full details of the disciplines that were identified as high risk, but certainly that you can recollect that it's physio, psychologists, and social workers. So that's so far your recollection. Can I just ask you, and you're going to have to get a bundle in front of you, to turn to 3381 of the bundle? Because there's something striking about your evidence here. Perhaps our secretariat can help you with a bundle.
Three, 381.
So at paragraph 5.4, are you there? It says this part of the analysis will consider the 12 disciplines with the highest number of FWA cases. This is a difference in FWA outcomes by race in 6 of these disciplines, and it's noticeable that physiotherapy, psychology, and social work are all there. And in relation to physiotherapy, it says the rate at which black practices are identified as FWA cases is almost double that of their non-black counterparts. In relation to black psychologists, in relation to psychology, black psychologists are almost 4 times more likely to be identified as FWA cases. And in relation to the category of registered counselors, dietitians, and social workers, black, let's say, social workers, counselors, and dietitians are more than 5 times more likely to be identified as FWA cases. Have you got any comment on that?
But I think the important part is that our testimony is that at the time of identifying and at the time of registering it, there's no race known to us. So I'm not in a position to, and we've in our testimony further that Dr. Broomberg will lead, we will demonstrate some factors that we do think can play a role in this disproportionality. But I can't factually respond to why there's a disproportionality in these particular disciplines.
Yes, no, I think the point really, Mr. Smith, and I don't think there's controversy to this, is that you see, you've accepted that there is a disproportion between black and white, and I must thank you for that. But what my colleague is doing is to give substance to the degree of the disproportion. That if you look at social work, and that's why I was trying to understand what are these discipline areas that you focused on, that the disproportion is 5 times. In psychology, the disproportion is 4 times. In physiotherapy, the disproportion is double. You see, I think that is really what is at stake. Not why is there a disproportion, but objectively, do you accept the scale of the disproportion?
Mr. Chair, if I can answer for my colleague, I think that, the facts are the facts. So that we're not here to contend against the disproportionality, including to the degrees that are part of our own evidence. But the question before you is not whether there's disproportion. It is whether the disproportion arises from race bias or possibly from other factors. And I think we have testified in great detail and provided full details on our process to Dr. Kimmy, who has himself testified that he sees no evidence of race bias in the application of our RRT. We've provided it to H&M, who have similarly made the point, and we've testified today that there are, right up until the point where the cases are allocated in, it's a set of objective criteria that are being used, firstly, and secondly, that nobody knows surnames until the case is literally already registered and allocated and on a digital system that then shows up the name. So we believe that, and then I've made the point that once the cases are investigated, there is no evidence of race bias because the outcomes are identical across black and white, with no statistically significant difference. So this does bring us and I think the panel back to the question of where and how does this often significant disproportionality arise in the initiation of investigations, and is there evidence in that initiation of either deliberate, explicit, or implicit race bias? And if I can make the point then to you that, as we've pointed out, Over 50% of the investigations that are initiated come from tip-offs, and I think it doesn't bear repeating that there can be no bias in that if you accept that we investigate every single tip-off case. And then it does become the single question to which we believe the panel must apply its minds is, where is there evidence of racial bias in the way the risk rating tool is applied and the way the results of that risk rating tool are applied to allocate cases into the system? And
Can you just tell me something? I hear your point, which is more argumentative than factual, and you have a right to make the argument. But I just want to get back to the factual side of things. I mean, we now know the disproportion, it's admitted by discovery. We also know the scale of the disproportion. It is also admitted by discovery. When did you first become aware that there is a disproportion?
So I think, thank you for that, and we are aware of some prior testimony. I have to tell you, and I think we've been very consistent on this, we have never, prior to the initiation of this inquiry, ever done any race analysis on anything in the entire Discovery Health system. And so the very first time that I personally, and I believe Discovery Health, ever became aware of allegations of race bias in our fraud and waste and abuse activities was in May of last year, when Dr. Gumede appeared on Morning Live. We had never, ever had either individual or collectively a complaint put to us about race bias. We certainly had complaints from some individuals about other elements of unfairness in our investigation processes. And as I said earlier, going back as far as 2007, so that's what now, 13 years ago, we initiated periodic external and internal reviews and governance to deal with allegations of duress, of unfair processes, etc., but not once. And I have to stress this, Mr. Chair, until sometime in May last year has anyone ever alleged race bias, and so we have never done that analysis. We've never seen the need to. We never thought it was an issue, and that's really the best I can answer on that one.
One thing that seems to be lost in this exchange as we zoom out into the big picture is my exchange with Mr. Smith. The point that I was trying to understand was that there is a proactive, let's say, identification of these disciplines, these three that I've mentioned, the physios, the psychologists, and the social workers. And looking at the report, and this is only come out now, we can see that those are the disciplines with the highest risk ratios that we found. So it does seem that there's something fishy, not fishy as in suspicious, but something's gone wrong here, because it seems a bit of a coincidence.
I'm not sure. I think Advocate Williams. I think the word's fishy, and even something's gone wrong.
Fishy is the wrong.
Yeah, sure.
I retract that.
Yeah.
But and also, I suppose we've made it clear to other people who have appeared before us that we are no kind of witch hunt to find intentional racism. We're genuinely trying to understand why there are these outcomes, which are deeply concerning to all of us, including you. So we're not looking for intentional racism. We're trying to understand the outcomes.
And
Let's say not fishy and not something has gone wrong, but the racial disproportion calls for an explanation.
It does. I fully agree with that. And you know, I think that what we are trying to point out is that it can only be, if there is race bias here, implicit race bias, to pick up on your point, Advocate Williams, if there is implicit race bias, it can only be happening in the application of the risk rating tool at some point there. We've tried to argue, I hope we've persuaded you, maybe not yet, that every step of that process until we're trying to find race bias in a process where it's race blind to our people and completely.
Yes, only you can explain this, because it's odd to us that in relation to where your proactive efforts are directed, that's where the very high risk ratios come out. I mean, it's
firstly, I think you're operating on the wrong impression. We're just giving you, this is a recall bias. You talked about behavioral economics. So one bias that's well described in the literature is recall bias. There's been a lot of the complaints in this inquiry have come from psychologists and social workers. There have been some recent investigations. I can assure you, when we show you the full picture over the last 3 years, these 3 disciplines we've spoken about, notwithstanding that they have high proportions, will be part of a sea of investigations. There are 80 disciplines, and dozens of them will have been investigated. So there is a recall bias, and which is why I've been at pains to ask for the opportunity to submit in writing. So we are in this difficult situation of knowing that the bias can only come in the initiation arising from the risk rating tool. We've explained to you not only is that race blind, but that it's based on objective factors, and we've outlined those factors. And as I will get to at a later point, because I'm desperately trying not to be argumentative, Mr. Chair, but factual, that Dr. Kimi himself has acknowledged clearly that the fact that you have disproportionate outcomes does not imply race bias. It's a correlation.
Yes, but I mean, it is the type of correlation that is so close to causation that it calls for an explanation. I just asked you, when exactly did you become aware of the race disproportion? And specifically on these disciplines, because you see, the problem is that and I know that we shouldn't be going into this area because you've asked for time, because it seems if social work psychologists repeatedly that you have no intention of discriminating, when the facts show that there is a disproportionate impact on black practitioners. So maybe you can postpone the issue to deal with later, and then you move on with your slide, but I'm trying to be fair to Discovery, to register our concern so that you can deal with it in a public platform.
I appreciate that, and with your permission, Mr. Chair, I think can we try and move to that part of our presentation that addresses this issue squarely.
Thank you.
And I'd like to start you at slide 59, section 6. I'm going to jump there very quickly for the sake of the audience. Thank you for the opportunity. I think that we've made the point, and I think Advocate Williams has acknowledged that there doesn't seem to be any concern about explicit race bias. We have never used race or other factors in identifying these cases. We've made the point that our analytics uses depersonalized patient data and only practice numbers. This has been confirmed by external review that you have in front of you. The Harris-Newpin-Molabatse review sought to look for profiling or similar biases, and you've seen their findings. They found no evidence of profiling or bias in the analytics. They confirmed that practitioners are identified only by their PCNS numbers. The database does not contain racial profiling data. There's no evidence of racial profiling when we investigate tip-offs. No evidence to suggest profiling in our statistical analysis, and they found that bias in the investigation processes would be detectable, and they did not find any. So I think I'd like to then skip all the way over to slide 63, please. I started my testimony this morning telling you how very seriously we have taken this. The allegations made in May came as a very big shock to us, and we took them very seriously immediately. We did a number of things aside from responding very diligently to your inquiry. We very actively engaged with the various doctor groupings that have laid complaints. We've actually been successful in resolving many of the outstanding complaints through those engagements. As I said, we commissioned external reviews, and we then decided for the first time ever to conduct our own surname-based analysis after receiving Dr. Kimi's report. And I do want to, if you'll indulge me, take you through that. On slide 64, and this picks up exactly your point, Mr. Chair. We recognize that if there is disproportionate racial outcomes in our processes, this is a critical issue. It's not our job to just deny it and bat it away. We want to know if it's there, we want to know why it's there, and we want to deal with it if it is there. So I want to then take you through what we've done and how that correlates with the evidence from Dr. Kimmy and also the evidence from our own, from Marius Smith that you were alluding to earlier. We did our own surname and first name in some instances based analysis. We had Deloitte do a very detailed review. That review is available to you. The details are on slide 65, the bottom, the methodology. So I won't go through too much detail other than to say we looked at 7,493 investigations, for the period January 2015 to June of 2019. We categorized these as black or non-black. I think you're aware, Mr. Chair, that there is subjectivity in this, and not everyone agrees on that names are black or non-black. And so we used multiple analysts, and we also asked Deloitte to check certain samples, and we found a very high match, but not a perfect match. So I think it's important to acknowledge the subjectivity in this, that there are particular difficulties, but which we highlight at the bottom of, or on page 66. There is subjectivity. Our so-called colored population in our country has names that can be classified, can lead to more confusion. And there are other areas, but be that as it may, we accept, I think, at face value here that both Dr. Kimmy's and ours are valid investigations for purposes of this inquiry. We then compared our investigation analysis by race to the underlying data set of practitioners submitting bills to our client medical schemes that had a total of 47,000 unique practices, and we had to take a suitably sized random sample of that and do the classification on that as well. And the results are shown on slide 67. And they do confirm, in broad terms, the findings from Dr. Kimmy. They show you that if you look at the very top row, Mr. Chair, in our total database of billing practices, 37.6% of practices are black, 62.4% are non-black. And if you then go down to investigations, you see the disproportionality. It's 55-44. So no dispute. I want to now please draw your attention to the lower two rows on this page, which provide the evidence I cited earlier, which is when you study our investigation process itself, the results show no difference in race in the outcomes. So the valid ratio is 74% and 75.8%, and there's no statistically significant difference. And the proportion of cases where we made a recovery, again, there's none. So to the extent that there is this disproportionality, which we concede, it comes through both the tip-offs and through the application of the risk rating tool. I then will turn to page 68 to emphasize.
These practices that we were dealing with, I mean, have you factored them in the 55%, 61%, and 49%?
Which cases?
The specific disciplines that we were.
Those are all in there, absolutely. This is the full database.
Yes.
So we've taken, this is the full, all the investigations.
Yes.
They're all in
I
there.
mean, the bottom line, Dr. Bloomberg, is that, Dr. Kimmy says there is a disproportionate impact. We had GEMS, which is one of the largest, also confirming that there is a disproportionate impact. Today, Discovery also confirms that there is a disproportionate impact. What this debate seems to boil down to is what are the explanations why black doctors are likely to be flagged for fraudulent, wasteful, and abusive practices.
That's correct. And to answer the very specific question before your panel, which is, is the explanation race bias, be it explicit or implicit? That is
Yes.
the narrow question.
Well, I mean, there are two questions at least before us. The one is to identify objectively, is the accusation, because you remember the black practitioners came here and accused you of targeting them for investigation. We had to investigate if that is true.
Yes.
I think everyone now accepts that it is, even if it's not intentional targeting, at the very least, the patterns of investigation show that blacks are more likely to be investigated than whites.
But with respect, Mr. Chair, that is not the same as targeting.
No,
I strongly
I-
disagree
no,
with that.
No, I accept that,
Yes.
even if one doesn't use the word targeting, in other words, intentional targeting.
Yes.
What we can agree on is that blacks are more likely to be investigated as an objective fact than whites.
Correct. And the
Yes.
question is why that would be the case.
Yes, well, you say that it's not because of racism, they say it's because of racism.
Right. Well, I think, but we believe that we have facts on our side, whereas the allegations are simply unproven allegations. And I think that's very important distinction. It's not a he said, she said debate here.
And what are the key aspects of your explanation for the higher likelihood of blacks being blacks being investigated? Let's not say targeted,
Okay.
but being investigated.
That's fine. So I will now, I will.
Sorry, I don't want you to leave slide 68 if there's anything important there that you want to raise, because
No,
this is, after all.
I would like to go through 68 because I think it builds me to answering directly
Yes.
the question you
Thank
just asked me. So I think the first point to emphasize to you is that our evidence shows that the differences in outcomes, in other words, in investigations, they arise from the process of identifying cases for investigation. I hope we can take it as proven from our data that even after surnames are exposed, there is no evidence of either implicit or explicit bias in our process because the results are identical. The same proportion of in black and white are identified as fraudulent, and in the same proportion of cases we make a recovery. So it does focus us only on the first half of the process.
Can I ask a question about that? I mean, I understand you clearly saying that your risk rating tool is producing this disproportion, and that's where we should be examining our, putting our energy. The thing that strikes me or bothers me about this is the risk rating tool is effectively it's software, or it's an algorithm, and there is someone behind that algorithm. So it's still ultimately man-made or human-made, so to speak. So there's we know that, and we also know there's human interaction with the results that this algorithm produces. So this is what's creating our problem. So
Yes. So I think, thank you. I think firstly, yes, it is in our case women-made. Our best data scientists are women. But I think there's a very clear next step there, which is there are 30 factors currently applied in that algorithm. We've shown those to Dr. Kimmy. He has studied them. We have studied them ourselves. We've asked additional external experts to look at them. Nobody can point out any implicit or explicit linkage between any of those individual factors and race. So you're right to say it's person-made, but I think you can't conclude that there's bias unless you can prove that one or more of those factors themselves somehow prejudice black people, black practitioners. We have to show that that does, and there is no evidence that it does. You know, if you had some kind of factor that was even questionably prejudicing, but Dr. Kimmy's had full opportunity and he has not shown that. We've subjected this to full scrutiny, and so that is a question that must be positively answered, not just left as this is man-made, therefore there may be bias. We've exposed the factors and we're asking it to someone to show us how those could lead themselves to implicit bias. The second point.
Well, my colleague has a question first before you proceed.
So the factors themselves may not be problematic on the face of it, but there's something in the way in which the factors, there's something in the way in which the operation works that comes to this result. So is that what you're going to be addressing us on?
Yes, to an extent, but I think but what I'm arguing quite explicitly is that even in the way that so the factors are not problematic, and we believe that the way the factors are operated and the cases are then allocated are also, no evidence has been put before you to prove either explicit or implicit bias. We've told you, repeatedly there are objective criteria for allocating, and nobody knows names until they're in the system after allocation. And so this does raise, which I'm coming to, I apologize for taking time to get there, what could be causing this correlation between race and being investigated, and is race bias, is it causal? The chair made the point that the correlation is so strong that it raises the question of causality. With respect, Mr. Chair, that is not statistically accurate. You can have extremely strong correlation with zero causation. I'd like to demonstrate our assessment of that to you now, if I can. At the bottom of page 68, Dr. Kimmy himself acknowledged no bias in the application of the risk rating tool. At the top of 69, we've spoken about the 30 factors and that there's been no evidence, Advocate Williams, of either implicit or explicit bias in those. If I can then take you to the top of page 70, Mr. Chair, this is the nub of the issue. Dr. Kimmy acknowledged in his report that the findings of disproportionate outcome, which we have confirmed and acknowledged from our own analysis, is only a correlation, and that the results provide no proof that race is a causal factor. I'd like to read into the record his quote. It may be that the relationship is clarified by some intermediate confounding variable, and that the causal relationship is between that variable and the outcome. This is a critical point before us today. Now, I wanted to give you an example here, and forgive me for using a very simple example, but I think for people who are not statisticians, and that's most of us in the room, this understanding the difference in causation and correlation is critical and not always completely obvious and intuitive. If I can ask you to look at the table at the bottom of slide 70, we've given you a hypothetical example here. This is a very important one of lung cancer. And if you look only at the first row and you measure the proportion of males and females with lung cancer, these are hypothetical numbers, you would see that 7.5 men per 1,000 have got lung cancer and 5 women per 1,000. And if you stop there, as we have stopped so far on race and investigations, you will naturally conclude that being male is a risk factor for lung cancer. The fact actually is that that's just purely a correlation. And when you go one level down, and you find that actually more men smoke than women, and when you bring in smoking, you'll see that exactly the same percentage of smokers between
particularly unfortunate example because it might lead us to conclude that the fact is more men, more blacks commit FWA.
No, that's not what I'm saying, with respect, Mr. Chair. Please give me a chance to get through the argument. That's not what I'm saying at all. Couldn't be further from the truth. I'm simply trying to make a point that there can be strong correlation, but when you look for confounding factors, you suddenly see an explanation. And this one is very clear. The incidence of lung cancer in this example is the same between men and women. So gender is not the right lens to look at. Smoking is the right lens. And so if I can now take you to...
I'm saying that the distinction between a factor that cannot be changed like gender
Yes.
and behavior that can be
Yes.
changed like smoking is
Yes.
a particularly unfortunate one.
Except I'm simply trying to make the point to illustrate the difference between a confounder, a confounding variable which explains correlation and causation. And if you'll let me finish, I think I'll make the point very clearly that we are not here arguing by any stretch of the imagination that black health practitioners commit fraud more often. That's not the point. If I can ask you to look at the top of page 72, Dr. Kimmy acknowledges that he did not have the data to analyze any confounding factors. And so he has to stop at admitting that he's got an association or a correlation, but he can't be he can't conclude that it's cause. We also want to make the point that his results show quite significant variation by discipline. So you already get the hint that you may have confounding factors here. We then, because we do have data on certain confounding factors, we have done that analysis. We are also subjecting it to external review, and we would be very comfortable if Dr. Kimmy or any other expert that the panel wishes to appoint wants to review in detail our analysis. But as I'll show you on the next slide, we have very significant results to put before the panel, which is that 3 factors that we've analyzed. On the fourth bullet point, 3 confounding factors reduce the observed difference in outcomes by more than 75%. So just 3 measurable factors. And so you already are moving from what Dr. Kimmy labeled a risk ratio of 1.36 in our numbers down to 1.09. And we want to argue today that there could well be additional confounding factors, measurable and unmeasurable, as well as environmental factors, and Dr. Williams, this is what you and I discussed much earlier today, that explain the remaining difference. And our contention is that all of this difference in outcomes, Mr. Chair, can be explained by a combination of confounding factors and environmental factors, and you do not need to conclude. In fact, there's no basis to conclude that there's implicit race bias leading to this difference.
What is an environmental factor?
So I want to ask you to look at page 74 at the second last bullet point. And if after that you'll indulge me, I would like to go back to the analysis of the confounding factors. This is the point that Dr. Advocate Williams asked me about this morning. We believe that it may be possible. We hear anecdotes to this effect. We do not have evidence, so I'm speculating in front of your panel, Mr. Chair. But we've heard anecdotal evidence that where practitioners are treating patients facing financial hardship, that they may be inclined to take actions that are not strictly legal because they're of the belief that they are assisting a patient in poverty, a family in poverty. So a very simple example would be a family that comes to the practice, to a GP, and says, I'm a member of a medical aid. My niece, doctor, my niece is not on medical aid. Could you use my card and please treat her? Okay. This is an environmental factor. That doctor may decide to do that. In our books, that is fraud. I don't think there can be any debate about it. I want to speculate here that it is possible that there's a correlation between black doctors and groups of patients facing financial hardship, and that could be an environmental factor. I want to emphasize that I'm speculating, that it's based on anecdotal evidence. We are not putting this forward as an explanation. We are saying very clearly there are clear confounding factors, and there may, I want to emphasize, may be environmental factors. So I am going to respectfully ask you not to put words in my mouth. I want to say only what I've said and not more than that.
Well, I mean, it's either we take this seriously or we don't.
Yeah, no, we must take it seriously. We're asking you to do that.
But then why then do you immediately put several qualifiers to the environmental factors
because,
and to put it tentatively if we shouldn't take it seriously?
No, because we don't, unlike all the rest of the evidence we're putting before you, I do not have any hard evidence of this. I don't have demographics that allow me to say a disproportionate share of practitioners submitting claims let me start again. We don't have evidence before you to say when we look at the average socioeconomic status of the groups of patients of different GPs, that more black GPs treat more poor patients. I don't have that evidence, and so I can't state this to you as a hard driver of this, but I can say that we have doctors who've said to us, I've had doctors say to me, I do this because my patients need the help, and I think the medical scheme can afford to look after them. That's
what I'm saying. If you are saying we should take it seriously, then we must interrogate it.
Absolutely. I
in
mean,
terms
you
of
might-
what it means.
yes.
Is your submission that the black doctors are more likely to be identified as FWA cases because they commit fraud in the course of trying to help other people?
I don't think I can even go so far as to say that, other than to say that it is possible, I don't know this, it is possible that when you look at the doctors who are serving the relatively lower income families within medical schemes, it is possible that a higher proportion of those doctors are black.
That's what I'm trying to understand, that you have to then reconcile yourself with the proposition. Because when you are a medical practitioner, you know the difference between honest and dishonest, between fraud and honest practice. When you decide that I'm going to put someone on as a beneficiary when they're not a beneficiary, you know that is fraud, even if your intention is to help. So you have to then say, well, black doctors will commit intentional fraud because they're trying to help others.
Firstly, Mr. Chair, we've got evidence and we've had cases of both black and white doctors doing exactly that thing. So I don't have any evidence as
You see, Dr. Bloomberg, I mean, I'm sorry to take you head on this because it is a confounding factor explaining why blacks are likely to be investigated. You drew up the example and you said I shouldn't put words into your mouth. I asked, should I take it seriously? You say I should. You can't now go back and say, oh, well, it's black and white, when you have used it specifically against blacks.
No, but I haven't used anything specific against blacks, Mr. Chair, with great respect. Firstly, I do still want to go back to the much more important part of our evidence, which is confounding factors. And I've simply said, and nothing more than this, that in addition to confounding factors, there may be environmental factors. Those may be that certain practitioners, in the belief that they are assisting poorer patients, conduct certain activities that are fraudulent. We believe they're fraud. We do not believe it's ever justified. I've made that point repeatedly. But all I can say is that in the service of the argument that you cannot conclude from disproportionate outcomes that there is race bias, that there are many other factors here, both measurable and unmeasurable, that may be at work here. Could I ask you?
Sorry, I just want to put this for the last time so that I'm not left with a wrong impression. Because it must be that the belief of Discovery Health, whom you represent, is that black doctors are likely to commit fraud because they're trying to help their poorer relatives or poorer patients.
It's not my belief, and it's not Discovery Health's belief, which is really why, Mr. Chair, I was wanting explicitly to avoid those words being put into my and my colleagues' mouths. I'll tell you what we believe. We believe that there are disproportionate outcomes in the investigations. We believe that there is no evidence that there is any race bias on our part, either implicit or explicit, at any point that leads to those. Therefore, we believe there must be other explanations beyond race bias. If you give me a few minutes, I will show you that 3/4 of the difference is clearly using scientific statistics attributable to 3 confounding factors. And then there's a residual, and I simply speculate that there may be other factors. I'm saying nothing more than that, and I do not believe anything more than that.
Thank you. You may then take us to your
Thank
3
you very
confounding factors.
And as you go to the confounding factors, you will, I just want to know, as you take us there, that the understanding we are to take away is that the confounding factors themselves have nothing to do with race. So you'll explain to us why smoking is analogous to the confounding factors that you are going to propose to us. So, yeah.
I'll try to do that.
Thanks.
I'm trying to remember my statistics 1 class from too many years ago. If I can ask you please to turn to page 73, it's 1 slide back. This graphic shows our analysis. So we start with the result that both we and Dr. Kimi found. They were slightly different, but we started with Dr. Kimi's risk ratio of 1.36. So we start here with, if you like, a 0.36 difference in outcomes. And what we do just methodologically is we add 1 confounding factor at a time to see whether that makes any difference. And so the first thing we add is we actually add discipline And interestingly, our result is this is not a confounding factor. The discipline in which the practitioner practices does not explain anything about difference in racial outcomes at all. It's not a confounding factor. However, when we look at the year in which the investigation was conducted, this suddenly becomes a very powerful. This reduces the risk ratio by over 19%. And we've tried to rack our brains on why that could be. There have been some changes over the years. Firstly, in the risk rating tool. So that has evolved. We've added new factors over the years. And so that has evolved. Secondly, over these years, there's been a significant increase in the number of tip-offs, the absolute number, and the proportion of investigations that arise from tip-offs. So those are two obvious factors to us that may explain why things are changing year by year. But it does tell you that when you separate out each year of investigation from the others, you get a 20% reduction in the difference in outcomes. And that's a very important confounding factor. The biggest one is whether or not the practitioner is on a direct payment arrangement. If you adjust for direct payment arrangements, you find this reduces the risk ratio by a further 33%, by a full 1/3. Again, Dr. Williams, Advocate Williams, we spoke about this earlier. I was speculating that one explanation for that as a confounder may be that patients and doctors, where doctors are not on payment arrangements, the patient is paying the account. And that may be the doctor may be saying to herself, himself, I can't change anything here and try and push the edges of legality because the patient will spot it, and or the patient is looking at the bill and calling the doctor's practice and saying you've made a mistake on the bill. Whatever it is, I'm speculating, it's a very powerful confounding factor. We then added in, because Advocate Hassim, we wanted to, you asked this question earlier, we wanted to test whether any of the individual 30 factors in the RRT themselves could be confounders. We added them one at a time. We found they make no impact. Finally, we added one last factor, which is, did the practitioner have a tip-off in the prior year? And that itself becomes an explanatory variable that accounts for another 20% of the difference. Subsequent to this analysis, and we haven't had time to update our reports, we also looked at geography. We looked at province. And what province does is it has a modest effect, a very modest effect. It reduces the risk ratio by a further 1%. And so if you ignore province, those three confounders reduce the difference from 36% to 9%.
Why would you use the tip-offs? Because according to your table 3 in your submission, which is at 3512 of the bundle, there's no difference between black and, as you put it, non-black when it comes to tip-offs, the distribution of
More or less
investigation.
50-50, yeah.
Yeah.
You know, to
Yeah.
be honest, I think our, I can't answer the question why. I can speculate. I can take a break and talk to our statisticians who I'm hoping are still here. I think they looked at a wide range of factors, and this was one of them. So I'm not sure why, but while I'm continuing to present, we will try and get that answer for you. You ask Angela. Angela here? Let's go and ask her why.
Dr. Brumberg, I think I'm now constrained to impose a lunch break. Unless you want to answer one question and then we take lunch or...
Thanks. I think thanks. Just to simply make the point that although the percent of tip-offs are the same, Advocate Hassim, they are still disproportionate, 50-50, but remember that only 38% of practitioners are black. So they're still disproportionate. So we wanted to ask ourselves, is this a confounding variable? That you're getting more tip-offs on black practitioners than there are black practitioners submitting claims. If it was 3862, it should have been a non-factor. But because it's disproportionate, we did want to test whether it was a confounding factor. And I think to conclude just before the break then, Mr. Chair, I think because there is clear evidence of confounding factors, we do not believe that it can be argued that this significant, as you pointed out, difference in race outcomes can be regarded as causal. We've eliminated 3/4 of it on 3 factors. There may be others that we could measure or we can't measure. We haven't had time to do an even more thorough analysis. I think, Advocate Hassim, just to finish on the smoking, I think the simple point, it may be unfortunate as in it's a behavioral factor, but I'd ask you to ignore that and to simply look at it at the simplest level, which is when you simply look at male and female and you forget about any other factor, you can mistakenly decide that masculinity is a risk factor for lung cancer. Until you look at something else that people do, in this case they smoke, it happens to be a behavior, but it could have been something else. We could have chosen a completely different example. You look at another feature, I could give you a different medical example.
I mean, isn't that your whole point there is trying to persuade us that we should take into account confounding factors?
Yes.
But if we accept that, then we don't need your smoking example.
That's fine. I mean,
Yes.
we wanted to illustrate how confounding works and how counterintuitive it can be. How intuitive.
Especially
can be
because
to-
you also deny environmental factors. So we should really stick to page 73.
I think there's a subtle distinction, if you like. We certainly want to emphasize confounding factors. I'm not denying environmental factors. I'm speculating that they may be, they may play a role. I think there's a difference. Thank you, Mr. Chair.
Thank you. We shall take the lunch adjournment. The time is 2:15. I think let's resume at 2:45. Thank you. Welcome back. Dr. Brumberg, we are still on your slide 73 with the issue of the confounding factors. I think you had just explained what they are and answered a question from Advocate Williams. Perhaps that's where we should commence the afternoon. Why is year a confounding factor?
Mr. Chairman, it's hard to answer that definitively. What we can tell you definitively from the statistics is that year is a confounding factor. That's a fact, which is very important, and it's a significant one. If you adjust for it, it does reduce the differential, as I said, by almost 20%. I did speculate why it might be. What could be the changes from one year to the next that might somehow cause this to be a factor? My speculations, as I said before, were firstly, there has been a changing trend in tip-offs from year to year in the period we've analyzed, with increasing numbers of tip-offs and a higher proportion of all cases investigated due to tip-offs. The second thing that we know has changed year by year is we have evolved the risk rating tool. Each year we analyze the results. We may add factors based on research. We may remove factors. Beyond that, I'm afraid we can't think of a reason why year would be a confounding factor here, save to say that it is a confounding factor.
What does it mean in practice? Would it mean that in 2014 you had more black doctors being investigated than you did in 2015?
Yeah, I don't have those specific details in front of me, and I think what it simply means is that once you account for year in which the investigation takes place, the statistics tell you that this is a variable that can explain the big difference in race of 0.36, which Dr. Kimi found, and which you rightly point out now needs to be explained. We are saying to you that statistical analysis clearly shows that 1/5 of that difference is simply due to the year in which the investigation happened. But I can't say more than that. I don't have the statistics and I don't believe we've even analyzed.
No, they were given to you in the report of Dr. Kimi, because he did, I think it was 8 years, but he did each year.
Show the years, yeah.
Yes,
Okay.
and then he came to the average of 1.36
Okay.
on I think a period of 7 years.
Okay.
So Discovery has them.
Yes. Okay. That's fine.
So you can't improve your answer. That's your.
No,
I mean, not that you can't improve it, but you can't take it further.
I think I can simply say that in none of those years has race ever been an issue, and if there are variations by year, they are due to some other factors to do with those years, and I've speculated on what those might be.
Now just tell me, when you began your discussion on confounding factors, I wasn't sure whether or not you were saying these are definitely confounding factors, or whether you were saying these are potential confounding factors, but they still need to be tested.
No, I think I'm very clear. We tested a wide range, and the 3 that we've demonstrated here have an effect, are clearly confounding factors.
So when I ask you then about the question of the year, and you say, well, you cannot explain because you don't have the year-on-year statistics, and in reality you do have them, why is that? Why are you unable to account for each year?
No, I think, Mr. Chair, so firstly, I'm not, I did not recall, there's a huge volume of paperwork here, I hope you'll forgive me. I did not recall the details in Dr. Kimi's analysis that shows the year by year. So I do now recall reading it, and I do recall the different numbers with his average. The simple point we're trying to make here is the year in which the analysis was done is a confounding variable when you look at the relationship between race and outcome. And nothing more and nothing less than that. Now,
Can you also just explain the issue of direct payments? You remember that at the commencement of your evidence, I asked you for a statistical breakdown of those people on DSP and those people on payment arrangements along race. Why did you put the direct payments here?
Because, as I said to Advocate Williams, I mean, firstly, our teams investigated very many factors, as I said before, and many of them didn't turn out to be relevant. So, why we put direct payments is to identify a potential universe of confounding factors, one has to apply, if you like, some hypotheses and some common sense. And our hypothesis, as I explained to Advocate Williams earlier, is that direct payment could be correlated with FWA and could be linked to FWA investigations for the reasons I said earlier. Firstly, when a patient, for a doctor not on a direct arrangement, the patient has to pay the bill. We hypothesize that there'll be more application of mind by that patient than a patient where the bill is being settled directly between the scheme and the practice. That application of mind could firstly identify patterns, and the patient could call the doctor. That application of mind, the knowledge of that could be a deterrent. So we hypothesize that direct payment could be a confounding variable, and it does turn out to be a very strong one emerging from the statistics.
But based on what? Because unless we know something about direct payments, we should know at the very least that your population, a base from which you drew the figures, there are more black doctors that are on direct payments than there are white doctors.
As I said earlier, Mr. Chair, we will give you exactly those numbers. I don't have them to hand. If you ask me to speculate, but please take this as speculation, I would say there would be a modestly higher proportion of black doctors or on payment arrangements than white doctors. So I would expect some disproportion. It could be, if you wanted me to guess, say around 20, is this 22? 22% more. Okay, so my colleagues are telling me that, okay, so you're saying that 22% difference from in proportional terms. Yeah, okay. So if you look at the ratio, if we take the ratio of black doctors who are on payment arrangements divided by all black doctors, that ratio is 87%. If you then look at the ratio for non-black doctors, it's 71%. So there's a higher...
Yes, no, that's the point I'm trying to understand, whether this is truly a confounding factor, because it seems itself to be linked to race.
It may be linked to race, but that does not, that still makes it a confounding factor, and it means that you cannot conclude that the race of a practitioner is the reason why they've been investigated more often.
No, I want to go...
It could be, sorry, Mr. Chair, my reason, which is you've got more practitioners in direct payment, therefore more non-white practitioners in non-direct payment, and therefore more of the non-white practitioners' patients scrutinizing the bill. That can be the causation. So you cannot conclude it. It may be linked to race. That does not exclude it as a confounder. It does not exclude it statistically. It in itself is an explanatory variable, and it does force you to question race as the causation.
Now, what are the actual figures here? Because unless we know the figures, it's difficult to know what. So you're saying it's 20, did you say 22% more?
22% more. So as I said, 87% of black doctors on payment arrangements,
Yes.
71% of non-black doctors on payment arrangements.
Yes. So black doctors are more likely, and what is the explanation for that?
Now that I'm afraid now...
It did have something to do with historical disadvantage
It may
and
well
the
do.
financial incentive to be
Correct.
on direct.
So if you'll recall my prior explanation, I think in my view, based on my experience, it's very closely linked to the socioeconomic status of the patient base of the doctor. So you're right, it is about historical, it may be about historic inequality and our history of apartheid. What drives a doctor to be on a payment arrangement, all other things being equal, is what is the balance between earning more by being off it, and can my patients afford the co-payments, and will they still come and see me? So there are parts of, so I think that's really that's the point here, yeah.
Now, just to understand this issue of direct payments, I mean, if you've done the numbers, when did you do the numbers to know that the 22%, the black doctors are 22% more likely to be on payment arrangements than white doctors.
To tell you exactly, I asked my colleagues to do this analysis in the last few days. What day are we today? Wednesday, Monday, Tuesday. Yeah. We also, so it was very recent as we were preparing for this hearing, when I've been traveling abroad, when I saw the direct payment as a confounder for the first time, I asked my colleagues, what is the proportion of black versus white participation in the payment arrangements? And that's when we got this. Also, we've used Dr. Kimi's race classification to get to this.
Yes,
So,
I mean,
yeah.
because what I'm struggling with is you also accept that the reason why there is this 22% split is itself a consequence of the historical discrimination experienced by black people.
I think it is, to the extent that you accept. I think you have to make a couple of assumptions there, Mr. Chair. You have to accept that my hypothesis that one of the main reasons why people accept payment arrangements is that they have, on balance, lower socioeconomic status patients. That may or may not be true.
But you want to use the same point where you say, I accept that the reason for it is because of racial discrimination of the past. You also want to use the same point to explain away racial outcomes.
Yes, I do, because the allegation is not about whether there's a history of apartheid in our country. That's, we all agree with that. The allegation is that...
Not a history of apartheid, a history of racial discrimination, which is the subject matter of this inquiry.
Yes, there's a history of racial discrimination which has led to an income distribution inequality in our country. That is not the same as saying that Discovery Health and its client medical schemes are practicing implicit or explicit racial bias.
It may be that they're just indifferent to it.
No, we are not indifferent to it.
Well, I mean, this is the point where you take people's historical plight as a subject that is historically disadvantaged. When we have racially biased outcomes, you say that must still be excluded because it is a confounding factor. It must be a neutral factor. That is why I say, are you not suggesting that Discovery, in fact, is indifferent to the historical racism?
I disagree strongly with that, with respect, Mr. Chair, because the history of severe discrimination against black people in our country has led to tremendous poverty impacting the black population of this country. These people are patients. They are the members of the medical scheme. That can never excuse fraud by a doctor regardless of her or his skin color. And what I'm saying to you is that we are very cognizant of the plight of our members. A majority of the members of Discovery Health Medical Scheme are black. Our duty is to them. And the exercise of that duty is being very diligent about fraud, waste, and abuse. And we practice no race discrimination, implicit or explicit, when we investigate and when we identify for investigation. And so it does turn out that participating in direct payment arrangements is a confounding factor. It undermines what you said is such strong correlation that you must suspect causation. This undermines your allegation, your contention. And it is a confounder. It may be linked to race. That does not mean that Discovery's racial bias is leading to the outcomes. It's a very important distinction.
Yes, but I'm challenging you on is that it probably does suggest, and you can disagree with me, that you are indifferent to the history of racial discrimination. That's the point I'm trying to challenge you on.
Yeah, but Mr. Chair, I respectfully, fundamentally disagree. There's no evidence that we are indifferent to that. I think I started by saying that we were shocked by the allegation. We've taken it with desperate seriousness and invested enormous resources in responding, both in terms of our own self-analysis as well as responding to you. But more importantly, we've tried to demonstrate to you, and we've provided a lot of evidence to back up our contentions, that at no point in our processes are we biased. And so I don't know on what basis you're saying we are indifferent to the history and the impact of our country's history on black patients or on black doctors. There's no evidence for that.
Can I ask you, since you know this inquiry began last year, but your own investigation, which confirmed racially biased outcomes only began on receipt of Dr. Kimi's report. Why did you wait for more than 6 months to do something about it?
I can tell you that we began discussing it intensively at that time. We were always anxious about an analysis like this on the grounds that using surnames has got all the faults that I mentioned before. We have never done any race-based analysis on any of our statistics. We were very concerned about untoward impacts of that, about creating unintended consequences, about offending people who we perhaps have categorized in one category or another. When Dr. Kimi's report came out, we took, and over that time we were in detailed discussion with our legal advice. After Dr. Kimi's report came out, our firm legal advice was, it is very important that you do your own. And so we chose to do it at that point. We were very concerned to do it before, but that was our decision after that report came out.
So the only difference was that you got legal advice after Dr. Kimi's report.
No, I think that we had been wrestling with whether or not to do it all along, from the very beginning of the investigation. At the margin, our judgment call had been not to do it. And after Dr. Kimi's report came out, and also after Advocate Trengrove gave evidence to you about where the onus would lie about proving or not proving the race bias when you get differential outcomes. On balance, the advice was you should do it, and then we decided to do it.
Can I just ask you just a general question? Given the size of your firm and the role that it plays in the economy, don't you accept that you had a duty, since these allegations surfaced? You said they are 2007, 2008, when you first got to know about allegations of racism?
No, that's not what I said, Mr. Chair. I said from 2007, we started to encounter certain individual practitioners alleging some unfairness in aspects of our process. The very first time we ever heard an allegation of race bias was in May 2019, when Dr. Gumede gave an interview on Morning Live. We had never, ever had any allegation of race bias before that date.
I mean, that is a bit odd, because we do have allegations of racism. I'm not sure if they're sent to Discovery, but certainly sent to the CMS as early as 2014.
No one has ever alerted us of that, Mr. Chair. The CMS, we have searched high and low. We have never had an allegation of race bias from the CMS, nor from any doctor, nor from any organization prior to May last year.
Yes, but you would accept that, barring your ignorance about the allegations of racial discrimination, if you had known about them earlier, you had a duty positively to take steps to investigate your systems and to satisfy yourselves that your systems are robust enough.
Yes, and what we did, immediately this inquiry was investigated, and even before that, when we became aware of the allegation from Dr. Gumede, we immediately started investigating every aspect of our systems. We commissioned an external review prior to the initiation of the inquiry. We did a thorough internal investigation. The only element we did not do was analyze our statistics on a race basis for the reasons that I have outlined.
Well, I mean, my understanding is that you say there was an external party that looked at the report that came from your internal actuaries.
Are you referring to the report in relation to
Dr.
the
Kimi's,
response
yeah,
to Dr. Kimi? Yes. I mean, we are. We had a significant, or most of the report that we developed has been reviewed by Deloitte. Yeah.
Thank you.
Dr. Brummer, can I take you to a table in Dr. Kimi's report that's in the bundle at page 3381?
Yes, I'm with you.
It's table 5.2, and it's an analysis that's based on Discovery Health data. And it's race and FWA outcomes by year. And it runs from 2012 to 2019. And if you just look at the risk ratio, the sort of the bottom line, basically, of the
second
entire
last one.
analysis,
Yeah.
it explains, it basically says per year how much more likely black practitioners would be identified for investigation, and it increases up to 1.66 in 2017, and then it drops quite remarkably to 0.97 in 2019. Can you explain what was the cause of that drop? What interventions were there that resulted in quite a significant reduction in the risk ratio?
No, I'm not aware of any interventions that we made that could explain that. So I would point you, Advocate Hassim, to the volatility. There's tremendous volatility. It's as low as 1.09 back in 2012. It goes up and down, and the change between various years is bigger than the change to 2019. So it seems to me there's random variation by year, just looking at it, eyeballing this without any explanation. And I'm not aware, I can ask my colleagues if they are, but I'm not aware of any factors that we changed in our processes that would change this outcome.
All right. Shall we then proceed with your... There's still a big portion of your presentation, which is the response to the individual complaints. So you can carry on.
We'll then move directly to that. Mr. Chair, can we assume that to the extent that we don't get to or haven't covered slides today, they are taken as part of our submission in any event?
Thank you.
Thanks. So I then will please ask you to look at slide 75. A number of allegations were made to your panel, Mr. Chair, throughout the inquiry. We believe that the vast majority of them were without foundation and were incorrect, and we have responded to those to you in writing, but for purpose of this hearing, we wanted to summarize some of the most important allegations in our response to them. The NHCPA alleged that 80 to 90% of audits are conducted on black practitioners. You've had our data now. The real number is 55.7. And so that's a false statement, and it's an example of many of the statements which are simply wild and unfounded, and without any evidence to support them. The solutionist thinkers and the HPSA both said direct payment mainly affects black doctors. I think we could quibble with wording. I think it's common cause now after the data I've shared with you that there is a higher proportion of black doctors that participate in payment arrangements, but the truth is 87% of all GPs in the country and 91% of all specialist visits are involved in payment arrangements. So it's not true that payment arrangements mainly affect black doctors. That is simply not true. 71% of non-black doctors are in payment arrangements. Solutionist thinkers allege that medical schemes are white-owned. I'm not sure I need to rebut that allegation, but medical schemes are owned by their members, and the General Household Survey from our government statistician confirms that 2/3 of medical scheme members are black. So that is clearly a false statement as well.
What are the discovery statistics?
Do we know our statistics? We don't have that data, Mr. Chair. We've not done a surname analysis. Discovery, we have 3.5 million members across 19 schemes. We've never analyzed that. The next allegation is solutionist thinkers about confidential information. I think with respect, we have had that discussion led by Advocate Williams. I think we've acknowledged that some of the information requested is not necessary. We've acknowledged that we should always proactively tell practitioners they are free to redact. And I think I've made the other points on that. Solutionist thinkers and the Independent Pharmacy Association argued that it's unreasonable for practitioners to be asked to keep records for 3 years. We respectfully disagree with that. The Health Professions Council requires doctors to keep records for 6 years, and pharmacy, the council requires pharmacists for 5 years. No one's asking them to remember what happened 6 years ago, but to keep their records so that those can be audited by regulators or others. Solutionist thinkers argued that doctors should have a clinical discretion as to which codes to use. Just write things down for me, please. Oh, you're just moving this. Sorry, apologies. Okay. This, we believe, is inaccurate. Every healthcare system in the world has standard coding systems and guidelines on which codes to use. These are actually controlled in our country by the Medical Association, not by the funders. I think it's also important to emphasize to you that any doctor or other health practitioner actually uses a very limited number of codes in their practice, somewhere between 5 and 20 or 30 codes at the most would ever be used. And most practice managers and doctors are completely on top of the codes that they want to use. And we're not here talking about finger error or other coding errors that we do deal with under the timeframes of regulations 5 and 6. So when there's fraudulent or otherwise intentional abuse of codes, this is not because doctors are confused about codes. Generally, health practitioners are very aware of the codes that apply to their practices. I think Discovery also, we've let you know in writing, invests a lot of resource in educating doctors, in advising doctors and other health practitioners who have a field force that updates them with coding. So we do not accept ignorance of codes as a reason for fraud, waste.
Doctor, can I pause you on that before you move on? So we've heard, of course, a lot from the doctors about the confusion, and we did put it to GEMS yesterday as well. And one of the problems that has been identified that has been presented to us is that there are a number of coding manuals, and that's where the problem arises. So even though Discovery might employ one particular code, other schemes may employ other coding manuals, and that's where the confusion may arise. Is that fair? How would you respond to that criticism by the doctors?
Firstly,
And just to say, in the context of what we know to be a historical problem of coding and the NHRPL and tariffs system, which the market inquiry itself found to be a lacuna.
We certainly have a very complex coding environment, and as the market inquiry said, there's a great need for updating and so on. But firstly, there is actually generally one billing manual that's owned by the profession themselves. Where I think the description you gave is accurate is that not every medical scheme or administrator agrees to pay for every single code in the doctor's manual. So the SAMA every year will add codes. So there's a huge historical legacy of codes that are paid for. At the margin, in a year, the surgeons will say there's a new procedure, we're going to add a code. It's then actually up to the medical schemes, because it's not coordinated any longer, to say, yes, we will pay for that code, no, we won't. And then it is true to say, if you're a surgeon, you may actually not know in your mind that the new code for this procedure is not paid for by Discovery. But we are talking about quite a marginal confusion. This is new codes. The vast historical legacy are there and paid for, and the vast majority of codes that any discipline you could name bills for are standard codes that are paid for by everybody. But when you get a confusion like that, a doctor submits or a practitioner on a code that we don't pay for, that never leads to a fraud, waste, and abuse investigation. That would lead to a claim being rejected, a message going to the doctor, an interaction, They may persuade us that we should pay for the code, in which case they'd be paid, or it remains clear that that code won't be paid for. So there is some coding confusion, but in our view, that does not pertain to abuse of codes. It's not germane to this inquiry's mandate, in our view.
Isn't the point really that a medical practitioner sitting in Springs gets one code from Discovery and another code from GEMS for the same procedure?
No, that's not true. Firstly, the direction is the other way around, Mr. Chair. So a practitioner in Springs sees a patient. The practitioner is a GP. She sees a patient for a urinary tract infection. She will have a short list, usually her practice manager, if she has one, will have a short list of codes. It will say it's a consultation, that's got a code, that's standard for everybody. And there's an ICD-10 code, standard manual, a disease code for urinary tract infection. The doctor, her practice will send the same bill to Discovery and let's say to Bonitas. Now it may be that they then, Bonitas comes back and says, we don't pay for that code. Or Discovery comes back and says, we don't pay. I can tell you that we will never initiate an investigation of fraud, waste, and abuse on one code that's being wrongly applied. If there's an extensive pattern, we would investigate it. And even then, if there's just a bona fide error, practitioners are innocent until otherwise proven. So these coding confusions, we really genuinely believe are at the margin, and they're not linked to fraud, waste, and abuse. They are a source of frustration for practitioners. We acknowledge that, and we're trying to work with the regulator and the Department of Health with the impetus of the HMI to deal with them. And we are very proactive with our doctors and working with them on coding, but that does not mean that that has led to or explains or justifies fraud and abuse.
What do you see as a solution to that problem?
I think it's very simple. Simple to say, not as simple to implement. Prior to 2006, you may know, Advocate Hassim, that there was quite an organized bilateral process between the health professions and medical schemes. They would come together once a year. They would update the tariffs, which are different to the codes. The tariffs is what gets paid for each code. So they would negotiate on tariffs, and they had organized bilateral processes for updating coding. So there was one, if you like, coding Bible that everybody applied to, and every doctor in theory should have known what could be billed for, and every scheme should adhere to that. That was unfortunately disrupted by our competition authorities. And the solution would be to get back to a form of that, obviously without risking collusion and the unintended consequences of price collaboration. Should I continue, Mr. Chair?
Yes,
Thank you. On slide 77, NHCPA and solutionist thinkers allege that the suspension of direct payment to practitioners is unfair. Our response to that is, firstly, medical schemes by law and under their rules have no obligation to pay a health professional directly. The obligation is to pay a lawfully rendered health service to the member. And that's the contractual relationship. And as I've stated, direct payment is a voluntary arrangement entered into voluntarily between the scheme and the practitioner, and therefore it is actually fair, should the scheme elect to do so, to suspend that. And as we've testified, suspensions occur in a very small minority of cases. Our most recent data at any one time, around 0.2% of practices. That's a total of 70 practices over around 35,000 are suspended for direct payment. And really it's in extremis. It's where a practice is refusing to engage with us, or where practice is repeating an offense that they've previously acknowledged was wrong, or where there's a very large fraud happening and we need time to ensure we can control it. So it is an extreme measure applied very far. In their words, a thumbsuck. We deny this. We use a very standardized and systematic approach to estimating the quantum. It is based on the data from that practice. It's based on detailed interaction with the practice. We ask, once a practitioner has acknowledged that they do something, we ask, well, how often do you do this? What proportion of consultations would you have written a false sick note? And we would base a calculation of money owed back to the medical schemes on the practitioner's own information plus our statistics. We are always open to alternatives, and I think if you studied the full history of the settlements that are reached, you'll find that in a very meaningful proportion of cases, Discovery accepts a lower settlement proposal on the amount owed than it originally proposed to the practitioner.
May I ask a question on this point? Can you explain, or perhaps why it is that you don't calculate the actual losses experienced by the scheme as a way of determining what is paid back?
I mean, so can I take my example of a false sick note and to try and explain to you how complex and how difficult that would be? So we have a tip-off that Dr. X is issuing false sick notes. The tip-off comes from an employer who's very concerned that a doctor in their area is issuing false sick notes and large numbers of the employees are not turning up for work. We go through investigation. In the course of that, the doctor acknowledges that he has been writing false sick notes. The loss experienced to the scheme, aside from the fraud of that action itself, the loss is what that doctor's doing is submitting a claim with an ICD-10 code on it for a disease code, and the scheme's loss is the payment for that consultation. How do we determine the total losses? Because we've now have, if we go back over 1 or 2 or 3 years, potentially many thousands of claims for consultations from that doctor, which have been automatically paid. There is no way of knowing which ones were valid or not, which ones were generated after a false sick note was issued, and which ones were when a sick child actually came and was treated by that doctor. And for us, we could, but think about the logistics of this. Try and go back and phone every one of those thousands of patients who were seen by them. And bear in mind, we're talking about 10,000 investigations a year on practitioners, 4,500 a year on practitioners. 4,500 investigations, each of which has thousands of patients a year. You're talking about, we'd have to investigate one by one, literally millions of consultations. In our view, it's very fair to say to that doctor, could you tell us, you estimate, how many times a month did you do this, doctor? And
Why should they give you any number?
I think that at that point we're in a process of saying, look, we have identified fraud. We would like to reach a settlement with you. We believe we'd like to continue paying. We accept your assurance that you will never do this again. In the interest of that settlement, could you assist us in assessing the losses your conduct has caused to the members of our client medical schemes? You have caused losses. You have defrauded the medical scheme of a certain amount of money. We can't ascertain that.
Why should they give you a number higher than the number you can prove? I mean, isn't it simply because against their neck is the risk of termination?
I think that is I think that you're right. You make a good point. We could equally make an arbitrary determination based on averages where practitioners have admitted. So hypothetically, if we look at the last 5 years, in the cases of where false sick notes were proved, the GPs have said to us they do this 50 times a month. We could use that number and say to the doctor, this is our default number. Please, can you give us a real number? You're right that they could say, I'm refusing to do anything more than you prove. Then we're at an impasse. And then the medical scheme must act according to its rules and also to the levers that it has. One of those is to say the privilege of direct payment is ours to suspend. We are asking you politely to cooperate with us. You've defrauded the scheme. By your own admission, you've done this. We are certain you've done it more than once. We've got a proof of once. Please cooperate with us. And Mr. Chair, with very few exceptions, we get that cooperation. The number they give us, I would imagine, again, just applying common sense, it may be an underestimate, but we take it at face value, and we then reach a settlement.
Would you report the doctor to the HPCSA in
Yes,
those
we
circumstances,
have-
regardless of whether they pay the sign an AOD?
We have, Advocate Asim, we have standard protocols for reporting. They're linked and driven by company policy as well as by applicable legislation. So I'll find the references in our slides in a minute. One of you guys can find it for me. But any incident which on its own is more than 100,000 Rand, we report to the South African Police Service. There's certain other criteria for reporting to the police, and there are defined criteria for reporting to the HPCSA. We never link the decision to report to whether or not a settlement was reached. We feel that that's a very important separation. You know, as we don't want to threaten, we won't report you if you settle with us. We feel like reporting must be legal and ethical and driven by those, and the settlement is a financial settlement to recover funds lost by the medical scheme and its members.
I mean, this is the point, I mean, about the actual losses, because we've had evidence here that schemes really never bother to find out the exact amount. And under the law, they are only entitled to the exact amount. Now, it seems Discovery admits that it actually never knows the exact amount, and it uses estimations all the time.
If I can, where are the slides on this one, guys? No. Slide 57 is the answer, Advocate Asim, to your question. I will come to your point, Mr. Chair, in just a minute. So, Advocate Asim, if I can appoint you to our fraud reporting on 57, if I can point you to that. Oops.
Is that 11% of cases were concluded only of
Yes.
those reported to the
Yes.
HPCSA?
Yes, and 5% to the SAPS. And this is an important point you pick up on, Advocate Hasim. Unfortunately, in our country at the moment, the statutory authorities and the regulatory authorities are not performing the deterrent function that they should be performing in our society. And it is part of the reason why we have to take fraud, waste, and abuse so seriously, because there isn't the deterrent. I think the average practitioner doesn't believe there's a very high risk that they will be sanctioned by their regulator or by the police. Which are the slides where we calculate the FWA? 41. Could I ask you please to refer to 41? And Mr. Chair, page 40, please, first. I want to, 40, slide 40. I want to argue against your statement that we don't try and understand the extent of the losses. We try to be as scientific as we can within some of the logistical constraints that I was pointing out to Advocate Williams. Firstly, on slide 40, we look at the specifics of each case. We try to estimate, you're correct that it's an estimate, as accurately as we can the quantum of losses. Part of the constraint here is also the burden of work on the practitioner. We could ask to see every single record for the last 5 or 6 years and go through those. That would be a huge burden for the practitioner, but equally so for us. We would have to employ thousands of people in order to do that. We always engage with the affected practitioner on the data. We always give the practitioner the opportunity to suggest errors in our estimate and to present their own analysis and proposals. And if I can refer you now to the next slide, 41, we have explained here our different methodologies for different types of practices. So I propose not to go into the detail here, but you can see from the next two slides that if it's a claim from a pharmacy or a dispensing GP, there is a methodology for an estimate. I acknowledge again it's an estimate. If it's a claim, a fraudulent set of claims for non-members or for sick notes, there's a different method. There's similarly a different method when we're analyzing purchase records, and there's a different method when we're doing audits for codes that are time-based, when a practitioner has seen a patient for 30 minutes, 60 minutes, 90 minutes, etc. So there is as much science as we can possibly apply. We do apply. I'm acknowledging to you that proving the loss in millions of claims would simply be impossible. And if medical schemes were forced to do that, I'm afraid what you would have here is a situation where the incentive would very much be towards doing more of this for practitioners, because you may or may not be identified. And if you're identified, you're hardly going to have any damage, because the medical schemes will not have the resources to prove every single loss. And at worst, you'll end up having to pay back a small amount of the benefits you've gained in an untoward manner. So the risk here is that you hobble the ability of schemes to engage in what we believe are legitimate estimates that are agreed to in the vast majority of cases. 90% of cases, we have agreements.
I mean, the problem is that the term agreement, excludes the fact that the risk on the doctor is that the scheme will just put them on direct payments.
Yes, that is a risk. So there's certainly some pressure on the doctor, but no doctor is ever coerced, ever forced. Many of them have legal representation. They have ample opportunity to provide counterfactual evidence, or to negotiate for a different level, or to deny completely that they've committed the fraud. They also have recourse. The medical scheme has a disputes committee. They have recourse to the Council for Medical Schemes to submit complaints, and they have recourse to the Health Professions Council. So there is tremendous recourse for practitioners. The truth of the matter is that the vast majority, if not all of these people, have committed fraud or other forms of abuse, and they are willing to acknowledge that and to pay back. The small number of practitioners who've made allegations, Mr. Chair, we will show you towards the end of our testimony, all of those have committed fraud, and none of their allegations are based in the facts.
Apologies for having to answer different lines of questioning from each of us. But what I'm grappling with is really a strict legal question, because Section 59.3 only entitles reversals in relation to losses. That's what the plain wording says. And so I'm having some difficulty with the argument that it should be interpreted to allow for reversals of reasonable calculations of losses. And part of the reason why is because this section was introduced, I think I'm not sure actually when introduced, but it was in existence probably early 2000s, before any of these data analytics systems were being used. And I wonder what the previous world looked like before you were able to run the analytics and do these types of audits. Were administrators and schemes at that point reversing real losses versus reasonable estimate of losses?
So firstly, I'm not a lawyer, and I'm in front of three esteemed lawyers, so I'm not on equal footing here, but we do not interpret 59.3 as the entitlement to reverse only demonstrated or proven losses. We do believe that a scientifically based estimate to which a practitioner has agreed constitutes a loss. There has been a loss by the medical scheme. The fact that we cannot afford the logistics and the investigation, it does not mean that there has not been a loss suffered. Again, I'm not very familiar with the full history, but I can tell you that going back at least the 15 years that I've been in Discovery Health, we have always been, and we've been doing analysis going back then, but it wasn't as sophisticated as it is today 15 years later, but even then we were estimating and trying to recover based on similar approaches to this, perhaps with less statistics. My colleagues are pointing me to 59.3b, which reads, any loss which has been sustained by the scheme through theft, fraud, negligence, or any misconduct which comes to the notice of the medical scheme. That's the language. So I'm not sure that implies proven losses. I think that our approach could be contained within the meaning of those words. Can I move on, Mr. Chair?
Yes, thank you.
I'm then going to go right back to where we were on the responses.
Sorry, Dr. Brumley, I just have to say one thing, just to get this out of the way, is that the HPCSA and the CMS, you pointed to them as recourse that the practitioners may have when they feel aggrieved by the negotiation process. But given what we said earlier, what you said earlier about the lack of whatever it may be, the constraints that is posed by those regulators, the fact that they are not functioning at the level we would like, doesn't really give the practitioners much comfort either. It cuts both ways, is what I'm saying.
I can't disagree with you. We have had certain practitioners test our processes in court. There have been, not only with Discovery Health client schemes, but other medical schemes as well. You'll be aware of some case law. And all the findings, whenever our matters have been tested in court, have been found in favor of the medical schemes. I do think it's worth just reminding the panel at this point, the very point in which I began, which is this ultimately should be about members of medical schemes. They are the vulnerable party here. They are here who we are here to protect, of course. And they are the party that the CMS is by statute there to protect. Of course, health practitioners are highly valued members of our society, but we fundamentally must look to the interests of these members. And the medical scheme is it's their vehicle. So that's why we believe the onus of the regulator, and we're hoping the onus of your thinking will be to make sure that any recommendations you make do not hobble the ability of schemes to legitimately identify, prevent, and investigate and recover when monies are fraudulently taken from them. If I can go back to the bottom of slide 78, please. The NHCPA alleged that recoveries from fraud, waste, and abuse are not passed back to the medical scheme. This is blatantly false. As I stated earlier, these funds never touch an account that's owned by Discovery Health. They only are ever in the medical scheme accounts. And wherever we can, when we can link a particular recovery to a particular member, the money goes back to that member, either into their savings account, or if they've depleted a limit in their benefits, that limit will be refreshed or replenished. And where we cannot link a fraud to a particular member, then the money will benefit the pool of members, the collective, by going back to the medical scheme. I think it's important also to make the point that the accounts of schemes are audited by external auditors and are reviewed regularly, quarterly, by the council itself. On slide 79, please, the South African Private Practitioners Forum and the Dental Association alleged that administrators suspend payment from practices before proving that fraud has taken place. That's not true, certainly in our case. We have standardized policies about when we suspend. It's very limited, as I said, 0.2%. And it's almost always after we've clearly demonstrated fraud or abuse, and we're simply not getting any cooperation. There are a handful of cases where we would suspend prior to concluding an investigation. This would be where very large amounts are at risk, or, for example, where patient safety is at risk, We've had examples of allegations of extremely dangerous practice in some part of the country, and we can get no cooperation from the practitioner. Can we visit? Can we send a doctor or one of our staff around to see? With no cooperation, we would then suspend before the end of an investigation. If I can take you to slide 80, Advocate Hasina Kasim made a number of baseless allegations. She said that our forensic investigations and our risk management processes are separate. It's incorrect. I'm not sure what she intended to mean by this, or what even was the base of the allegation. But all of our risk management is based on analysis. So is our forensic activity. Forensic activity is integral to our overall risk management. The statistical analysis we do overlaps both elements, and our teams interact extensively. So it's just simply not true. I'm not sure that it's relevant in any event. She contended that schemes do not have the authority to investigate practitioners, and she further contended that medical scheme rules only apply to members. And we believe that both of those are wrong. The Act explicitly supports the recovery of member funds from any party to whom they've been untowardly paid, including practitioners. So we believe the advocate is wrong. And secondly, it is not true that scheme rules apply only to members. There are elements of scheme rules that clearly involve any party to whom the scheme has paid funds. And so that is incorrect as well. Finally, and I have to say to our great surprise, Advocate Kasim argued that practitioners are justified in inflating claims, I presume she means fraudulently, because they are not adequately compensated. She gave some examples. We do not think an admitted officer of the court should ever try and motivate or justify fraud. There can never be justification for fraud or abuse. And in the case of Discovery Health, we do pay, in the particular example she gave, for the completion of forms when members need prescribed minimum benefits paid to them. Even though there's no obligation in the law, by the way, we do pay for it. But even if we didn't pay for it, or even if we paid way less than a health practitioner feels they should be paid, this could never justify fraud or inflation of claims, as Advocate Kasim alleges or contends. Mr. Chair, this brings us to some responses to the formal complaints submitted to the inquiry.
Thank you.
There were, as you know, we handled about 34 such complaints, and we've given you detailed affidavits in response to each. We summarized here 7 of them. We picked the 7 because they were practitioners who gave oral evidence before you. And so what I would like to do, if you'll permit me the time, is to summarize the overall findings, and then if you're willing to take you through the allegations made to you in oral evidence and our response. However, if you feel you're short of time, we won't insist on going through the 7 matters. Your instruction will be fine if you regard those as read. That would be fine. But then I will just
we have
summarize.
received your responses
Yes.
to each of them.
Okay.
And there might be some questions from Advocate Williams in relation to 1 or 2 of those examples.
Perfect.
So subject to that, you can give us the broad outlines.
Thank you.
Without going to the specifics.
I'll do that. Thank you very much. On slide 83 then, as I said, we've submitted 34 affidavits to the panel. We want to make the following key observations. Firstly, none of the cases contain any credible evidence of race discrimination. In all of them, there was a rational basis for initiating the investigation. Either this was a tip-off, or this practice emerged as a clear outlier in the application of our statistical analysis. In all 34 instances, we followed a fair process to protect the procedural rights of the practitioner. In all cases, We've done recovery calculations on a reasonable basis with reference to the details of each case. We've been lenient and accommodating in allowing practitioners to decide with us over what period they would repay the funds in order to ease financial strain. You know, I do think it's worth bearing in mind the counterfactual here, which is it would be perfectly in the scheme's right in any one of these cases either to insist on immediate repayment, with direct payment being suspended as a threat, or to take other measures. And our approach is we would rather the practitioner stays in practice, continues to receive direct payment, continues to be able to see their patients, but undertakes to repay the losses and undertakes not to commit the fraud again. And that is the basis, the principle of our action. Some of the complainants, Mr. Chair, have committed egregious fraud, and this calls into question the entire credibility of their complaints. So we now have one or two slides on each of 7 cases. As you suggest, I don't propose to go through them. We haven't named them. We were tempted to name them because they named themselves by appearing before you. We didn't think that would serve any interest, so we've called them Mr. A or Mrs. A, and we have a key, if that will help you, but you may be able to identify them anyway. But the details are here. You have the full affidavits. If there are specific questions,
Yeah. Could I just ask you a general question about? I mean, I know you say that every one of these you've investigated have committed fraud, etc. There is mostly a dispute about whether they have committed fraud, and there is no independent adjudicative system. The power is concentrated on the administrator of the scheme, and we now know that it's really concentrated on those 44 individuals who comprise the forensic unit. And those are the people who make the judgment calls about whether someone's practice, payments towards his practice should be suspended or not. And I have not seen anywhere where Discovery proposes an alternative method which would introduce an element of independence in the determination of whether someone is guilty of fraud or not. It seems what Discovery wants is to retain the power to decide on its own, even where there is a dispute, that somebody is guilty of fraud. Especially given this thing that really makes me uneasy. It's true that practitioners admit to instances of FWA, but they've come to tell us that we have to admit, because if we don't, the risk is that our practice will be terminated, and we will, people came here, they testified, they broke down, they cried. We have to assume that a lot of them were speaking in good faith. And on either instance, the risk that I just put myself as an independent practitioner. If ever there was a risk that if I didn't sign an AOD, my entire practice would be sequestrated. It seems to me that it would be a logical thing to do, to admit so that I can move on with my life. And I don't see anywhere where Discovery says, look, it's necessary to have a robust independent practice. Especially because we also know that these practitioners, it's not as if once Discovery has imposed the guillotine on them, there is an immediate recourse, because the evidence we have about the processes of the CMS are that it is virtually dysfunctional insofar as it is a dispute resolution body. So it seems at the first level, one must think about what is the fairest way of determining guilt and what is the fairest way of imposing penalty. But if someone is unhappy with that determination, there has to be a place where they can go for a recourse, which would be robust but also quick. But in this field, it looks like the practitioners really are at the mercy of Discovery.
So, Mr. Chair, I respectfully disagree that they're at the mercy of Discovery. I want to remind you that we don't arbitrarily and randomly call in practitioners and threaten that unless they pay us some arbitrary amount, we will suspend payment. Firstly, these days, approaching 60% of these arise from a tip-off. This is some external party giving us valid evidence that there's untoward behavior. The balance comes from strong statistical evidence. We then investigate. I do not accept, and we do not accept, that any of the practitioners who have claimed that they only signed under duress were not committing fraud. We do not accept that with respect. We believe that all of them have committed fraud and abuse. Very few of them, it has to be said, complained at the time that they signed that AOD. They signed it and they went about their business, and when your panel was initiated, they came out of the woodwork to complain. If I can, I think you now compel me, if you like, to give you an example, or some examples. Mr. A, an optometrist, we investigated this practitioner on the basis of a tip-off that he was supplying sunglasses. Sorry, this is on slide 85. Got it. We then sent in undercover investigators who clearly provided evidence. This practitioner gave our 2 investigators sunglasses and submitted false claims, fraudulent claims for payment. We asked him to a meeting. He freely admits that he does this, and he voluntarily undertake to repay the losses, in this case 5,000 rand, and he honored the repayment agreement. But he complained about being forced to do this and about racial discrimination. I'm asking you where the evidence is in that. And I don't want to waste the
Tell me
time.
on something else. No, well, I had to put the proposition to you, but let me just ask you something else. Where does Discovery get the power to send these undercover operatives?
We have advice from 2 senior counsel that in circumstances where we have no alternative ways of proving fraud and where there's valid prima facie evidence that fraud may be occurring, that it is entirely legal and within our rights and to use these undercover investigations. So we've submitted the 2 senior counsel opinions to you. We also have court judgments in our favor where the evidence has arisen from these kinds of investigations, and no judge in these matters has ever argued that the evidence obtained thereby was illegal. There are circumstances when a member and a practitioner is colluding, Mr. Chair, for example, around sick notes, or another example would be where a doctor suggests to a member, or the other way around, let us submit a fraudulent claim to a medical scheme for 400 rand and we'll split the proceeds half-half. It is impossible for us ever to find evidence of fraud like that unless we do this kind of undercover investigation. And again, I'm pleading with you not to take away from medical schemes which are there for the members, for nearly 10 million people in this country who depend on them for healthcare. Do not take away the abilities of schemes to deal with fraudsters. We could never prove that a sick note is fraudulent or a false claim was submitted without those undercover investigations. No statistical analysis, no. And we do not go and arbitrarily send these investigators to a practice. We do it when there's a clear tip-off with strong prima facie evidence. So we believe that it is legal, and we've taken advice to that effect. Mr. Chair, I'm aware I haven't responded to the second part of your question, which is about an independent process. We believe that if we could rely on an independent industry body operating efficiently with agreed standards and operating in such a way that it did not cost the members of medical schemes a vast amount of money and did not slow down these processes, if we could rely on all of those things, we would firmly support some form of arbitration body that could rapidly and cheaply handle these kinds of disputes. There is no such body today. I do not agree with your statement that the CMS is virtually dysfunctional as a disputes resolution process. It deals with a huge volume of disputes with limited resources, and in our experience actually deals with many of them well and as quickly as it can. But be that as it may, we're hopeful that collaboration with the CMS could lead to perhaps the development of this kind of body. We would hope that the ability to initiate investigations, to prosecute them, and so on remains in the hands of medical schemes, and the ability to reach agreements voluntarily remains between the scheme and the practitioner, but that you have an efficient body for arbitration of disputes. Bear in mind, Mr. Chair, that the vast majority of these cases where valid fraud is proven by us, 90% of them are settled very quickly and voluntarily. You have been exposed to a very, very small tail of aggrieved practitioners who've elected to complain. And many of them have no basis for that complaint. That's what our evidence also complains. So I'd urge the panel not to generalize from a tiny number of complainants in the context of 35,000 practitioners submitting millions of claims every year, not to generalize from those and thereby weaken an entire system that is providing great protection to the members of medical schemes.
Can I just ask one or two questions in relation to the complaints, or your response to the complaints? And just to start by thanking you for the detail that you've provided in the affidavits. They are very comprehensive on the whole, which is why there's no need to ask a huge amount of questions in relation to them. But I wanted to ask a couple, and if you don't have the personal knowledge, I'm happy for you to consult. But the one related to Mrs. B.
Slide 89.
That's
Yeah.
90. Well, I'm at page 91.
Okay.
The last bullet point. It was the third investigation, I think, because there's one in 2015. No, the second investigation, 2017. And at the end of that, she was placed. Her payments to her and her patients were suspended. And you testified earlier, as did the PO, that before a suspension happens, the scheme gets involved. So I would just like some information or some understanding of what interaction happened between Discovery Health and the scheme in relation to suspension of payments to this member and to this healthcare practitioner and the members, her members. Her patients.
Yeah, Advocate Williams, what I said earlier today about the involvement in the scheme was quite specific. It was not in decisions about suspension. It was in decisions about a permanent block on a practice. The difference is a suspension is temporary and is very often lifted once the matter is resolved. In fact, almost all of them, so it's almost a revolving door. And I'll remind you, it's 0.2% of practices. The permanent block is a much more onerous decision, and that's where the scheme is involved. That's at this point about 0.7% of practices, because that tends to accumulate because it's permanent. So the scheme would not have been involved in the decision to suspend payment in the case of Ms. B.
Okay, thanks for that clarification. Then if you turn over the page, she was eventually blocked in the next investigation in 2019.
Yes.
So the same question then would apply.
Yes. So I don't have literally the minutes of a meeting, but if standard practice was obeyed, that decision would only have been made by a committee that involved executives, officials of both Discovery Health and the Discovery Health Medical Scheme in this case. Can I just confirm with my colleagues? If you wish, we could provide minutes of that meeting. Yes.
That would be helpful. Thank you. And then my only remaining question is, I understand, well, let me be sure I understand your general submission is that those who gave evidence, you have made quite a serious allegation against those who gave evidence and that they're effectively fraudulent.
Yes.
And so I am obliged to kind of put this to you, but I'm not convinced that all of them were fraudulent, and I just want to draw your attention to one of the examples so that you might reconsider that position. And it's Dr. Molepo on page 1601, and this is your response to Dr. Molepo, so I'm in a way giving you a benefit of the doubt. But even on your affidavit, I'm not convinced, so I'd just like to understand why you believe he's fraudulent. Sorry, egregious fraud.
What did he originally do? So if I understand from my colleagues correctly, I acknowledge your point. I think that in this case, there's no firm evidence that this practitioner committed fraud. So I do withdraw it as applying to all of them, and apologize for that allegation against this particular practitioner. Mr. Chair, I think as agreed.
I mean, we can, I suppose, qualify the point. I mean, look, there's a serious statement. It's not made by you. I'm sure it's made by your forensics people to, justify or explain themselves. The fact is, it doesn't matter if all of them have committed fraud or some have committed fraud, because we're looking at this from a point of view of principle. What is the fairest way of dealing with them, which protects the interests of your members, which you say are a priority. So I suppose the general point is that in some cases there is serious fraud, but in others there may be no fraud. I mean, I think we can all settle it on that basis.
Agreed. Mr. Chair, I think if I would then move directly to our concluding remarks, which are on slide 113. I'm skipping then all the individual cases. If I could ask your indulgence on 110, I'm going to very rapidly. We brought for you here a few case studies to just give you a sense of the extent of some of this fraud. Again, without bothering you with the details. This is a tip-off regarding the conduct of a cardiologist who submits claims to our schemes. This turned out to be losses conservatively estimated at 9 million rand, which were freely admitted by this cardiologist. And he refunded the schemes, our client schemes, this amount. On the next slide, a practitioner who was qualified as a radiologist. What this practitioner was doing was stealing consumables, expensive consumable items used in radiology, for example, to insert a catheter into a patient's heart, stealing them from Chris Hani Baragwanath Hospital, using them on private patients, and submitting claims, so benefiting for the value of the cost of those where he had stolen them from a desperately resource-constrained public hospital. He freely acknowledged this loss to the tune of 6 million rand and is repaying that amount. Pharmacy fraud to the tune of 4 million rand. I think you get the point here. This is a minority of practitioners in our country. We've shown you that it's more or less 8% from one time or another. Many of these are not serious, and at the tail you have things that are as serious as this, but we feel obliged to investigate these and to prosecute them.
The problem, I mean, I also looked at the Smolepo example because it stands out as an instance where Discovery actually made the mistake. But the problem is, it's not so much how you catch the guilty. The problem is how you make sure you don't apply the blunt instrument against the innocent. I think most of us will accept that the guilty parties should be dealt with and they must accept the consequences. Yeah. But I think the point of the existence of a fair system is not how to catch the guilty, it's how to not catch the innocent.
Completely agree. I think just to conclude on the case of Mr. Molepo, we still believe very strong evidence of significant concern with the billing practices from that practice. We never were able to prove that. There was never any acknowledgement of that, which is why I withdrew my statement as suggested by Advocate Williams. But we have not had any cooperation from this practitioner. So we've got strong prima facie evidence. This is a practice that is a significant outlier relative to others. And payment remains suspended. There's no reason why that practitioner can't find some acceptable way to share records with us, invite us to his practice, share redacted records, prove to us that our suspicions are incorrect. So I'm not saying that he's innocent. I am acknowledging we have not proven fraud.
I mean, the problem is that you've acted despite your admitted failure to prove anything.
We've acted in one way, which is we've acted to remove a voluntary privilege which is granted to him by the medical scheme in order to, and it's not a contractual obligation, as I've said, in order to encourage him to please cooperate. All he would have to do is provide us information. I do not understand why he would not do that if he's got nothing to hide.
He's told you why. He's not prepared to breach patient privilege.
We don't.
Sorry, that's actually the example that I had put to you earlier of someone who is in an area where it's difficult to sort of scan, email, and so on, and indicated that he is willing to share the files, the information with you. So it was the one in relation to the question of whether you would visit the practice in such an example.
I do think the onus is on us to make all efforts to assist a practitioner to cooperate, particularly if they're extenuating environmental factors like you've mentioned. So we will go back and look in particular at that one. The impression I have from my colleagues is there was more willful, deliberate, intentional non-cooperation. That's our impression. We may be wrong.
This is why we're having this conversation about most schemes have come to us and presented us these like horror stories of, look at how much we're bleeding, which we are sensitive to. I think the real issue is how do you deal with instances of innocent people that find themselves as victims of what I've described as a blunt instrument. That's really the test. So the one way is to insert a fair process prior to you acting. The other is to insert a robust process post your decision, but making sure that it's quick and it delivers speedy justice. So that seems to be the two debating points about you saying that it's unfair to impose it prior to us acting. It's better to do it post the decision. And the doctors, on the other hand, feel it should be done prior to you acting.
So I thank you. Yes, I think you've put it very clearly, and our very, very strong preference, and I would almost put it as a plea to the panel, if you're going to make recommendations, is for a robust, efficient, cost-effective process afterwards. I think if you force schemes, if you prevent schemes from taking action before, and this results in delays and frustration of the ability to investigate, you will overwhelmingly harm the interests of members of medical schemes, and you'll be defending the interests of a relatively small number of practitioners who are committing fraud, and a tiny proportion of that small number who are perhaps unfairly caught up here in a process when they are truly innocent. And I think the balance of harms is what is on your plate. My colleague has pointed me just to one last statement in relation to the case of Mr. Molepo, which is that, his statement to us, his last statement to us, Advocate Hasim, has been, it's our responsibility to contact each one of his patients to verify the claims that he submitted. That's non-cooperation from our perspective. We can't do that. If he were to suggest, please come and visit my practice, or send someone to redact everything, I think that would be a different matter. Mr. Chair, if I can conclude then on slide 113, just with some concluding remarks. I will move speedily because you've heard many of these before. We've told you that this problem is serious and an increasing challenge for schemes and their members. We've told you that schemes and their administrators have a clear legal imperative to actively tackle this problem, and that failure to do so or material impingement of those processes will pose a material risk to the future of medical schemes. We invest, as we've told you, significant resources. It has been effective over many years. I did skip over a slide, but I did mention to you that just over the last few years, we believe the premiums of Discovery Health Medical Scheme would be 14% higher today than they would have been without the fraud, waste, and abuse activities. We hope we've provided you with compelling evidence that we and our client medical schemes have never, ever resorted to race profiling, to racial bias in any form, at any time, in any of our processes of identifying and investigating fraud, waste, and abuse. And we believe that we've demonstrated strongly now that to the extent that there's disproportionate outcome, it arises from a very circumscribed area of the triggering of investigations. We believe that your own experts have confirmed no explicit or implicit bias in that area. And we therefore think that what remains is a differential that can largely be explained by confounding factors. We want to conclude by reminding you that we continually have had external legal review and counsel opinion, as well as court judgments that confirm that our processes are fair and fully compliant with legislation. The observed differences which we acknowledge in the proportions of practitioners, black and non-black, who are investigated arise specifically from the process of identifying cases for investigation. They do not arise from the process once the investigation is underway, because we've shown you our data that the results of those investigations are identical once they're in the investigation pipeline. We've told you that the majority of cases identified for investigation arise from tip-offs. Today it's over 60%. These are outside of our control, and we investigate every single one of them, so there can be no bias there. We've told you that the balance of the cases arise from the application of our analytics. I think you have interrogated us deeply on that. We have provided full details of that to Dr. Kimmy, also to H&M attorneys. We will provide you additional information that you've requested during the course of the hearing today. Just to remind you that that risk rating tool uses 30 independent metrics, none of which are related to demographics. Despite detailed scrutiny by Dr. Kimmy, as well as by external experts, no one has brought forth evidence of any race bias in our risk rating tool or how we apply it to the investigations. And we therefore conclude that our conscience is clean in relation to implicit or explicit race bias in our fraud, waste, and abuse investigations. Dr. Kimmy himself conceded that the observed race differentiation, I'm now on slide 115, does not per se demonstrate bias on a racial basis. He conceded confounding factors. We have demonstrated to you that 3 factors explain over 75% of the race differentials. The remaining differential is 9%. I did explain, not in writing, that if you add province, it goes down to 8%, and we believe this is attributable to either additional confounding factors, which may or may not be measurable, and perhaps other factors as well. Dr. Kimmy confirmed no evidence of explicit bias in our processes. We have submitted 34 affidavits in detail to rebut the complaints made before you. And for all of these reasons, Mr. Chair and members of the panel, we firmly maintain that there is no implicit or explicit race bias at any stage in Discovery Health and our client medical schemes processes, and that no convincing evidence of such bias has been presented to the panel. I want to reiterate that that does not mean we believe our processes are perfect. I think you've already hinted today at some recommendations that could bring a greater degree of fairness with efficient, rapid processes of recourse for aggrieved practitioners and others caught up in this. And I'll just reiterate, we are open to any of the recommendations that are put forward by the panel, and we will gladly adopt any of those we believe to be effective and important. I think you've heard me make the point repeatedly that there is a genuine risk here that inappropriate recommendations and remedies on balance, could cause more harm than good. They may restore rights you perceive to have been injured by practitioners at great cost to the rights of medical schemes and their members. And I think that concludes our evidence, Mr. Chair and members of the panel. Thank you very much for hearing us today. Thank you.
Thank you. Did your experts rely on separate data, or did they use Dr. Kimi's data?
No, so our internal statisticians performed a separate analysis using our data. So we provided Dr. Kimi, obviously, with the same underlying database of practitioners and members and fraud investigations. Our analysts then performed our own name-based analysis, partly alone with multiple analysts. Some of it was done by Deloitte, and Deloitte also checked some of ours. And then Deloitte also reviewed our methodology of our analysis. So it has been externally reviewed, the confounding analysis. And if we haven't already done that, have we provided the Deloitte review? Yes. We have provided the Deloitte review.
Yes,
So,
no, I'm just talking about the underlying data that was used.
Yes.
If you, and the analysis, if you could provide that to Dr. Kimi.
Okay,
Because he now needs
the
to
full
review.
confounding analysis too.
Yeah.
We'll describe the data we used, the methods, and so if he wants to review it, yes, we will do so.
All right, thank you very much. This will be the end of today's inquiry. It remains of me to thank, well, your colleague is here. I understood that she was meant to make a submission, or what is the plan? The principal officer.
She should speak for herself.
Yeah.
Thank you very much, Mr. Chair. I think Dr. Brumberg has covered the bulk of the aspects from a scheme perspective, particularly at the beginning when we spoke around the governance framework that is utilized by the scheme, and some of the aspects that he's spoken about that we are engaging on around how do we also have an independent mechanism to enable practitioners to dispute when there are matters that they would like to dispute that are being investigated. But other than that, there is nothing else from the scheme side that we wish to add in addition to the presentation that Dr. Brumberg has made.
All right, thank you very much then. I just wish to thank you, Dr. Brumberg, for taking the time to respond. I think there were one or two times where you were late, but for the most part, you were always on time with the responses to all of the queries that we raised, and the fact that you've prepared for this thoroughly and for the time you've taken to come and present at this inquiry. It's not always been a happy occasion, but I think it's an important one. We will adjourn until tomorrow when we are hearing from Met's scheme at 10 o'clock. The inquiry is adjourned.
Thank you.
Thank you.